yesterday, joined us yesterday as Chief Medical Officer, and I think also at this point acknowledge the work that Anne has done for us over the last couple of years as Acting Chief Medical Officer, so welcome. Also like to extend a warm welcome to members of the public who are joining us today. Thank you again for joining us. It's a real pleasure to have you with us. I think we'll start our meeting with a karakia. Josh.
Yeah, good. Morena te whānau, I'll stand. Please stand. Me noi tātou. Manawa mai te Māori nuku, manawa mai te Māori. Kei au te Māori tipua, kei au te Māori tāwhito, kei au te Māori nōhia. No tiki tiki o rangi, no te waioro o tāne te waioro. Tēnei te Māori ka whakapiki, tēnei te Māori ka whakakaki. Tēnei te Māori ka puta ki te whai au ki te ao mārama, ki te matatauira e tua ke nei. Uhi, wero, tau mai te Māori. Haumi e, hui e, tā e.
Kia ora. Thank you. I think we'll press straight on into the agenda. We do have the Cognitive Institute joining us at 11 a.m. So for those who are familiar with the Cognitive Institute, it's they have been leading for around 5 years, Jim.
Easily, yeah.
Program across DHBs, which is really about safety within the workplace, professional accountability. So they will be joining with us to update us on the program that's running here. We've got a relatively light public excluded agenda and then some matters that we're going to deal with in board only. So if we start with our public agenda, apologies, Nga will be here in about 10 minutes time. I'm not sure if Amy is also running a bit late.
Oh, she isn't texting.
Okay. Item 2.1, schedule of interest for review. Does anyone have any additional interests to declare? Right. If any come up during the month, we can just email them to Rachel. And any conflicts in relation to today's agenda items? Carl? So we move to the minutes of our open session of our meeting from the 23rd of February. Does anyone have any comments to make on those minutes? No, then I think we can adopt those as a meeting. Any matters arising? Check my notes, I don't think there was. And if not, Jim, if I can. Oh, I'm sorry, I do have one matter arising. So on page 9, the reference to the treaty and equity training update. So it was all on a bit of a hold at our last meeting. Then during the course of the month, there's been some quite rapid developments and the dates have now been circulated by the ministry. The optimal date for us and to Hauora and the time in Miha to all join together for this is 24th and 25th of June in Referral. So the intention is that it starts around lunchtime. There's an afternoon session, an evening session, a morning session, and finishes around lunchtime on the second day. So it'd be great if as many of us as possible can attend that. The broad intention is to look at how us and our Māori Partnership Board can better understand treaty and equity and be working together to improve how we improve outcomes for Māori. So that's the broad intention of the we're hoping that as many Te Manawa-Taki DAs and their partnership boards can join together for that one so that we can get our whole region, how we do this as a region, particularly in light of the regional plan.
Amy's on the way.
Amy's on your way. Okay.
Can we get a number on that for that?
Yes, Rachel, can you send that through for diaries? Yeah, thank you.
Seems a long way out, but
yeah.
Send the better, please.
So the registration information has previously been circulated, but yeah, if you can follow that up, Rachel, thank you.
Can the 1 hour session said
so the 1 hour
training.
Yes, the 1 hour session I've signalled to Matua Pita that given that we now have basically a morning, overnight, afternoon, overnight, morning session that we'll hold on the 1 hour session at this point and try and get the board sort of coalesced around the bigger training session.
So sorry, the dates again, Kate?
24th and 25th of June. There were some other date options put out by the ministry. And again, those have been circulated for, I think, in Christchurch or Dunedin, Waitangi and Auckland, maybe. And if people can't make it, though, that is an option to attend another one of the venues. But from my perspective, I think it would be great if we can work with the team on that. I'll pass now to you, Jim, item 4.1 for the action items from our last meeting. It's at page 14.
Yes, so that suicide incident review that the board wanted to report on, that has been completed now. I discussed that with the Director of Area Mental Health Services last week, and she will create a short summary of it for you to review next month in committee. You've got Donette Kupinga and Taylor Hainga from Hauora. They're scheduled for next meeting. You wanted a debrief from Rhythm and Vines, which is on the agenda today. April for the next one, the performance dashboard, those figures are now coming through. There's going to be an update in the paper in the Hauora meeting from Surgical Services on those. And there's been no progress around that, extending the data collection for alcohol-related ED presentations. And staff assault, just an update there about what has since followed up in relationship to that.
So Jim, the Rhythm and Vines is the paper on the next page.
Yes, so that was the paper that was presented to Kahui Whakahaere, not to Kahui Whakahaere, in March.
So has anyone got any comments on the action items?
Oh, not the action items, I've paid that paper.
Yep, yeah, that's one of the action items.
I just wanted to check, did we monitor COVID-19 trace app usage at the festival? And if we did, can we get an understanding of its usage? I did note in the paper that there were very few checked, but I wondered if that's the government app that we encouraged usage of. I'd specifically like to think that we're tracking, monitoring usage of it in any events that we're a part of.
I don't know if we get the details down to individual places like that where we can check. Do you know if we can get it about what from the ministry?
We get percentage usage, but we'll check.
Is that at a regional level rather than an event level?
Yeah.
That would be useful for us to understand in COVID updates.
Yeah.
Sure.
Particularly the number of people
There, and then
actually who checked in.
I don't think we can get that event level.
No.
we can't keep
Yeah.
No, that's what I'm saying. I'm not sure you can actually get at a particular spot of the
Totally wrong.
QR codes how many people went past that and scanned, but we might be able to. But you could then divide by the total number of attendees, but then you would have people coming and going. And,
Yeah.
over
But
days.
even information on usage across the community in our region would be good information in our.
So, it has peaks and flows as we do with testing. Every time there's an event, it goes up and then down again.
Just as a random sample, how many QR code are coming in here today?
Me.
It's not an
It's not too bad because I think the rate is really low in the country now. Yeah. So but
Bluetooth, baby.
should be 100%. shouldn't
No,
it?
you've got to scan as well, Bluetooth, ain't enough.
Yeah, I was just gonna,
I know that at the Rhythm and Vines, they had that team dressed up with the Bluetooth, doing like little video clips and highlighting the need to stay alert. To
Then you have to scan.
Around the whole
So, yeah, I think it might be pretty close to 100%. Yeah.
I've got a question about the same report. So when I read that report about the R&B, at the end of it, it says what didn't work as well. And there's quite significant headings of what didn't work as well. So then I flick back to the recommendations at the bottom of page 17. And to me, the recommendations didn't seem to capture or align with addressing some of the big stuff that didn't work well. Is the stuff that didn't work well actually was planned for but just didn't work well? Or what is the plan to address stuff that didn't work well? Because there were some quite strong themes coming through that report about
things like drug testing sites.
Yeah, staffing issues, challenges for staff, and there's quite some specifics picked up on that didn't work well. And just when I read the report, I felt it didn't actually provide a pathway for resolving those issues if they arrive next year. And I thought, gee, we're going to read a report next year which reflects the same report. Similar issues.
Well, I mean, we're improving the response in conjunction with the other partners around fines every year. And I thought that in the recommendations there, I mean, a lot of it was around that mental health support on site. And that's recommendation number 1, early planning to ensure a better presence on site. So I think that has covered what were the major points. And we do put a lot of effort in every year to review what happened last year and improve for next. And it's also some of those ones there. This report covers also other aspects around Christmas, New Year period, around like the meal day options. So that's covered in there as well.
Were there particular concerns?
It was the vibe. No, it's just a sense. I don't know. I thought discharge planning, the new candidate didn't return the paperwork on time. The ICU patients placed in ICU due to skill deficits on the ward. I don't know. They seem to be sort of systemic things, and I just did feel that they were picked up. But if you're telling me they're picked up in the recommendations, then I will rely upon your word.
You're getting a summary report there. It hasn't really gone down into, we'll do this or that. But I can absolutely assure you, each year we do review and we do follow up on those recommendations.
Good. That's good to hear.
Sorry, I kind of have a conflict because I did volunteer in the Haven space, which is in the report. So I've fed through to R&V's management our concerns, which are, noted around the mental health. And we were just appreciative of the staff that were gifted into that space because of that expertise. The concerns were simply that a number of incidents after drugs ingested high and anxiety and mental wellness spaces. So we were concerned about people going home after having quite a traumatic event. Obviously the loss of a life. There were students we met who knew the young man, so that there were quite a lot of hysterical young people in that space. And so it was mostly about, we kind of send them on their way after the event and hope that they get the help at home to that space. We weren't sure on how could we ensure the safety and wellness once they leave Tairāwhiti.
So that did happen, and there's a mechanism that kicks in directly after there's a suicide event. It's called post-vention follow-up and support, and we were involved with being able to connect with the places that people had, that the individual and their friends had been involved with it at uni, and also the home space.
Oh, okay.
Feeder in, we weren't key to it because the person didn't come from this area, but we were certainly part of ensuring. So the key people that picked up on that were the home where that person resided.
Yes.
And so we engaged quite early in the piece to ensure that those things were being covered off by them.
So thankful for the report. Thanks, Jim and team. And because the debrief space, we weren't really clear on who attended in respect to our space. I'm assuming someone from that space went to share some of the concerns we were seeing in respect to those debrief dates. But
for this debrief. So Kate Mather pulled the team together from the District Health Board that were involved with it, and it's from their feedback that she's put this together.
Okay.
I have to confirm with Jim that there's a series of debriefs over a period of years since R&V's been running, and each year the improvements are situated in there. So the wellness space, for example, wasn't existent 3 years ago.
Exactly.
So those are things that have improved over time. And so now that we have that, we're becoming much more refined about what else is needed in that space. So it is a
ongoing improvement.
It's an ongoing improvement quality.
I guess that they are starting to realise there's more and more needed. I did talk to management about the drug testing, but of course the cost to them. But
actually, it wasn't approved for this year's events. It will be approved for it actually came into place post R&V, and so those things that are noted there recognised, and you'll see the tents that'll be available this year.
Cool, thank you.
Okay, moving right along, there's a couple of items of correspondence of note in this session of the meeting. The first is about the health capital funding envelope, where we have been one of HDHB's approved funding through that envelope, up to $2 million for a generator and an electrical upgrade. Jim, I think the pertinent thing for the board in this letter is that the business case has to be done by a specified time, otherwise the funding will get reallocated. So
Yes.
do we know the time frame for that?
I don't think we've been informed the time frame of it yet, have we? But it does, they say that they did say that they would be in touch with us directly, when I got the phone call from them saying that they'd approved this, and also some other things on site that they want to talk to us about as well. So
Craig, can we get, just make a note to include an update for us on that particular business case in financial report, just so that we sort of keep our eyes on, make sure we don't exactly keep that funding?
Sure, yeah, I'll have a conversation this afternoon with so the key members from the health and construction units. I'll wait for them.
Okay.
So the
Tony.
second paragraph of that letter, for share that come within your DHB in confidence. No public announcements could be made at this time.
oops.
Okay, done.
Yes, correct.
Moving right along, the code of conduct,
Well, the press,
page 24.
press is behind us anyway. We're live, but
Page 24. The SSC has issued a new code of conduct that applies to us from mid-April. And amongst other things, it requires us to have a board charter or governance manual. So, Jim, can you just update us on what our particular documentation in there currently looks like, and what kind of review we need to do to make sure?
You've got a
That
governance
fits.
manual,
Yeah.
and you've got operating, operating guidelines for the work of the board. So it will need to be updated in relationship to what this Public Service Commissioner is here.
Okay, so
Just quickly back on that generator electron supply. It's kind of, yeah.
so what's our process for doing that?
I think we need to get your current paperwork out. You can have a quick look at it to see what you think needs to be updated in relationship to this.
Right.
But I think in many respects, when I read this, this is kind of like a set of, I think in most respects, you just need to endorse this, because I can't see that you would want to do a lot to change that or add more to it, given that it is being formulated by the Public Service Commission.
And it's been done.
I think we need to get to
We need to act on
comply
it.
with it.
Yeah.
The question of what,
Yeah,
how we do that,
yeah.
how we give effect to it.
And that it is reflected in our governance documentation. Right?
Correct.
Yep. So I'll get that out for you. You can have a look.
That'd be great.
Yeah.
Okay, moving along now to item 6.1, the performance dashboard at page 28.
Yeah, I'll just note a few things there. Probably others have seen our immunisation rates have taken a little bit of an improvement, which hopefully is the start of a better trend in relationship to those. Certainly a lot of work has gone in with our HO partners and our outreach immunisation service to improve that. You will also see a little bit further down there the newborn enrolment and general practice, a big jump there in the statistic. We've signalled all along that the figures there haven't been, the data hasn't been accurate, and our PHO partners have worked with us to get that more accurate and reflects what we believe to be the actual situation.
Just sorry, Jim, is that a data correction rather than a concerted effort to increase enrolments?
It is, yeah, it is reflecting more accurately what the actual position is. Something to do with the way in which the information was flowing out of the practices into the PHO and then on to this reporting that comes through the ministry. And we were significantly different than other DHBs, and that was because of the way in which the data was being processed across both PHOs. And just probably the only other one that a couple of there was around commodity treatment orders that Māori are continuing to decline under a target now and on a downward trend in relation to those, and our consistent high use of the emergency department. And last, I've talked about it many times, the 0 to 4 entry sensitive hospitalisations, but not meeting target around our 45 to 64 rate, although there's been a significant reduction for Māori since last year, still not down to what we would want, and we've got some work going on about how we may decrease that further.
Has anyone got any questions on the performance dashboard, Tony?
Page 29, under hospital events, missed appointments. So it's got Māori 13%, total population 8. I just wonder, as a reporting mechanism, it's quite a blunt tool. Does it really capture, a person might miss an appointment, but do they make a reappointment? Does it capture reasons why they don't attend? It just seems quite a blunt stat. If it doesn't really portray what it's intending to portray.
So it's measuring people who've had an appointment made but do not attend that appointment, and there's a variety of reasons why people don't. We don't necessarily ask them at the top, obviously they haven't come, so we don't know why they didn't attend. So we've done a lot of work over the years in terms of surveying people, contacting people to try and find out what are some of the reasons why they don't or haven't been able to put it more correctly. And there is a number of projects that we put in place to try and improve that. For instance, in paediatric outpatients, there's a person whose job it is to coordinate outpatient appointments. We know that there are factors such as people sometimes don't know that they actually have an appointment, so they've not attended to the fact that their GP has made one for them, or they weren't necessarily thinking an appointment would be useful for them. Other things happen in their lives that they're unable to attend on that day and aren't able to make contact and let us know all of those factors. So yes, we do rebook people. We do try and follow people up through other means to try and find out if there's reasons why they aren't able to attend, lack of transport, those sorts of things. We know that there is problems sometimes with postal service that they don't get the appointment letter on time, or that not the postal service, but the address has changed, and so it gets sent to the wrong address. We check with people when we do have contact with them to make sure that their address is current, but that can change between that time. The national system has got an address in it that we utilise. It needs not just us, but primary care to also make sure the address is current, so that we're sending the appointment. There's a wide range of reasons why that rate is that, and a large it exercises a lot of people's minds about how you can improve that statistic. I wouldn't take that drop off for this month as a sign of better times. It's there's a lot of effort in there, but as you can see, it bobs around quite a bit.
Mm-hmm.
I do just want to mention too, this was brought up in Iwi Te Rangi, and outpatients nurse manager and a paediatrician outpatients clinical coordinator, I think is the position, are working on a text and calling model, because particularly with our older whānau who may be relying on post, or like they may be not getting the post thing and then getting a text out of the blue, like there's some comms things that are
so we text people, we phone people, we've got some specific roles around trying to ensure that people know about the appointment right start, and that we book them at a time that maybe suits them better, rather than what happens mostly is that we get the referral, we process it, we make a time for people, send them out a letter. We try not to send that too early because people forget, and we try not to send it too late because that people are busy and they need to be able to schedule it in. So it's a sweet spot of when you get best results, all of those sort of factors to
Do we put community kaiawhina with that?
Yeah, that was also discussed at Hiwai Perangi. We've actually asked for a fuller report to come back to us. Because we discussed the multiple strands of how we could encourage and awhiao and aki our people to come along to the appointments and stuff. Community kaiawhina working in collaboration with our iwi health providers, sending out posts, texting, calling, follow up of missed appointments. So we've kind of asked for a fuller brief to come back with a lot more detail.
Thank you.
With the bow screen, I know it's too early to be putting back, but I did have an inquiry from a 75-year-old, and 75 being the new 65. The age bracket 65 to 74. What happens with the? Do they have to get a referral through a GP to get bowel screening, or?
They wouldn't get screened. That would be symptomatic at that point. So they signs and symptoms of bowel cancer and attend their GP and get a referral direct in for a scope. And the GP can make that referral, and those people are just go straight through to scoping.
So, the really early intervention is probably not going to happen.
Well, the screening program is designed around an age band, as that is the most effective age to be screened. So, there's going to be a point at 74. Beyond that age, that is back to people being aware of signs and symptoms and seeking advice and help from their GP or phoning Healthline if they've got symptoms, and obviously similarly younger people as well, because bowel cancer also affects younger people. But that's at the moment the screening program is in that age band. It may extend as time goes by.
Just as a comment, it's really quick turnaround. I did it myself, and I didn't even think the letter would get there by the time I got the results. It's going to seem to be going pretty well.
Very good.
Just a comment regarding the referral of obese children. The numbers of children in this space growing. I mean, in respect to that, I was just I've been attending Huringa Pai, and I wondered if we get information, because there's a lot of children that are attending the classes, I noticed, on Tuesdays and Thursdays, and a lot of these really big chubby kids are going along and exercising alongside parents, etc. And I was really just aware that there was actually quite a few kids there. And how are we finding out who's, I guess, working alongside children who suffer from this in the space of obesity? How are we collating data? Is it growing in numbers, or is it just played the same? I was just interested because I was fascinated seeing all these people.
So this screening relates to the under 5-year-old age group.
Okay.
Assessed in their final full school check process. And so if they're under 4 and they're attending an adult physical class, that it's not what we would expect. So there's a program of work primarily through Sport Gisborne that looks after the whānau. That's not excluding Te Huringa Pai, but Te Huringa Pai was not actually set up at the time that these programs were established.
Right.
But we expect that the way in which it's being delivered is through a Māori support focus. And they have actually employed Māori into the program at Sport Gisborne to run those programs.
Right. Okay. I'm just wondering, are things getting better in the space of our children? Because this
No, not in the same
respect. So thank you.
Okay. Just moving to item 6.2, my report. So just a couple of things. The weekly meetings with the Minister and DHBTs have resumed. So the first one that I re-attended was on the 19th of March. And just the key messages that came out from the Minister of things important to him were the vaccination strategy, reinforced mental health as a priority. We talked about the fluoridation decision, sending those decision-making rights to the ministry, and also noted that new builds would now be expected to contribute to carbon emission reduction goals. So we might need to think about what that means for us in our capital works program. And we also talked a bit about cervical self-screening, and we're going through the discussion with the Minister about where that's at. Gavin attended the one following week on our behalf. Anything of note in that one, Gavin?
The subjects were unsurprisingly sort of the COVID vaccine and rollout, and there was a point, Jim, that the Minister made there was additional funding available for the rollout. He was just raising sheer awareness of that, so
Yes.
apologies, I meant to email and just check we were all over that.
Yes, we're aware of that. Yep.
And there's general discussion on the issues of rollout. The Minister was particularly interested in how engaging with iwi and the communication teams, and then capital planning, which nothing particular note. So it was a reasonable discussion about the upcoming timing of the vaccine rollout and the interconnection with the flu vaccine or not, and the priority of COVID over flu in the decision making.
Sure. Yeah.
Yep.
And then there are some other matters, but I'll talk about those a bit more later in the meeting. There is the report from Tairāwhiti. Okay, so we'll just
wait for now. I'm sure now.
Is in the meeting room now. He's got no video and no sound on though. So
okay.
Not really in the meeting at all.
Hang on.
Oh, there he is.
Boy, oh boy. Hello, kia ora everyone, morena. Sorry my tardiness, I was a little bit late finishing work and then some hosting issues, but we're here. And I just emailed my quarter into you, Rachel, but then we'll just speak to it, shall we?
We're just going to get you some more volume.
Okay.
I need to hear you.
It's unusual for me to be so quiet.
Yeah, no, we got you now.
All right, so I don't know if you heard my earlier spiel. I just finished work a bit late this morning and we had some hosting issues. And I sent an email through just on the issues in case I missed the meeting, Rachel, but I might as well speak to them now. And I'll just go and find what I sent you so that I don't say it wrong. There we are. Okay, kia ora everyone. So just a couple of points from the Te Waiora Nukutai Memeha hui last week. There was a presentation by Ross Lawrence and I forget his offsider, a lady.
Maybe?
I think it was. Yes, their presentation was for the lung health checks for Tairāwhiti. One of the things that was really prevalent for us was the fact that everyone who presented would get a health check. And so we thought that was at least a really good start. And if criteria was met, then they would go on for the investigation. The second thing, we really looking forward to the Tiriti and Whakanoa training as a whole of Te Manawataki. I think that's a brilliant concept for all of us to get together in a room, not only Tairāwhiti, but all of our groupings. The third thing we did was, amongst other things, was we supported the concept of the proposed vaccination program, particularly the involvement of iwi providers. We thought that was a really good connector. Same with Ross Lawrence and connecting in with the iwi providers as well. So we just wanted to note that we don't have financial authority, so our support was for the concept of and total call for that to go forward. That's what everything was. That's why everyone was waiting in anticipation of our report. I know.
Does anyone have any questions for now?
There was one thing I'll just say, we ran out of time to start our wānanga around the terms of reference. So this goes back to the iwi hui, Tairāwhiti iwi hui, asking for a review of our terms of reference, but we've penned that for our next meeting, and So cutting down our agenda, but getting into the terms of reference as a part of a process, we would start that and then maybe go direct with an iwi, I should say, and ask them to be in on the start of that action. So all of that, though, would all ultimately come back to this board for discussion.
Right.
Thank
you, Hauora. So we'll move to item 6.4, page 30, and pass to you, Jim, for your TEs.
Thank you very much. Just some particular highlights in there for me, or points to raise in there. I've started off just with that, what I'm calling highlighted month, just something that can start some thoughts. And I've just put in our influenza coverage by DHB for the last year. And once again, Tairāwhiti's led the way for the country on this. Why I've put it there is that it really demonstrates to me that, when you line things up, when you've got something that people understand, and you make it available to them in a way that they can get to it, you get really good response rate from that. And obviously across the country, you can see that many DHBs also had good improvements this year in that program. So to me, it really does bode well for our COVID-19 vaccination program in Tairāwhiti. We've got 38,000 people to vaccinate between now and the end of October, and we've got a plan about how we're going to achieve that, working with iwi around that. But this is a particular group of people, and possibly more amenable to thoughts around vaccination. But I think that it's demonstrating that, as I say, when you set it up, and you make it available in a way that people can access it, then people will come and take advantage of the protection that they've got from that. So really, it's a good starting point just to keep in our minds in terms of planning for going forward. And we can talk a little bit more about COVID vaccination in a moment when we get to that. Financially, not such a good month last month. We had still having quite a bit of expenditure there around our outsourced services, and that will be the same again this month, as we've been getting in some additional help around catching up with planned care. And so those are particular cost areas within that, and also our staff costs were up a bit this month, as well as those outsourced costs as well. When you're looking at the year to date there is a number of drivers around our off-budget position, and some of those are related to COVID costs, COVID expenditures, a little bit in relation to COVID costs themselves, but also we are seeing that large, significant increase in our leave liability that is for annual leave and for CME leave, as utilisation of that hasn't kept up, and people are not taking leave at the moment, although despite encouragement, and certainly not CME, as that tends to be overseas related. We are utilising more medications in Tairāwhiti than was initially signalled by Pharmac and budgeted for. So that's running at about $500,000 more than what we expected at this point. We do think that that may track back a little bit towards the end of the year, but it's certainly driving a negative variance at the moment. And we've got currently our $1.2 million of non-specific and Holidays Act accrual in there. In Craig's report, we can come to our projection for this year, both over bottom line and business as usual. So we're our clinical supplies costs are up. We're seeing more people through. This is a phenomenon around the country in terms of more people coming through the health system. You've heard some publicity in the last week or two of DHBs. We haven't reached that point of code black as they have done in Southern DHB and in Northland DHB, but certainly our numbers of people coming through a little bit better in February, but December and January, as you'll see later in the graphs there, were quite considerably high months. And you can see that on the bottom of page 32. with the numbers of people coming there, and where we had some improvement in, we've still got some flattening off in trend in relationship to acute admissions, but with those bumper months there, if you'll see on the top of page 33 in internal medicine, for instance, in December and January, that trend is not quite so flat as it was before. Pediatrics looking really good. Most of the other ones are pretty much the same. Pleased to see that in general surgery, in the bottom of page 34, that increasing trend is now stopped, and we're just hovering around a new level of monthly referrals. ED dropped back again in February. We certainly couldn't have continued on sustaining those really high levels that we were seeing in December and January. Part of that, of course, being our usual December, January peak with additional people in town. And of course, this year there was much more internal tourism of people coming home for that period of time. So put more pressure on our systems. We may pick up some revenue from that from people who are out of district, who we get inter-district flows for. Too early to tell about that yet. And just again, good performance there from our teams in terms of the flat conversion of, no corresponding increase in conversion of people attending to admissions, which is indicative of the difficulty sometimes people have to access primary care and come to our emergency department. Instead, also bearing in mind that tends to be higher over this Christmas New Year's period because people aren't involved with a general practitioner in our district, because they come from out of town and so come to the emergency department, and also that we provide the out of hours general practice services after 8 o'clock every evening through till 8 o'clock the next morning, and for many practices that have an on-call system in the weekends, we also tend to pick up a few of those people as well. Our planned care volumes continue to be higher than in prior years, particularly around case weights. We are, and from a funder point of view, the main pressures are there around our personal health expenditure, particularly in areas of pharmaceuticals, and a bit in disability support services as well. That's for over 65s. In those key indicators, I already talked about improvement there in immunisation. Planned care production, we have put in a lot of additional effort in the last month or two to try and really dig into some of those persistently difficult areas. For instance, in ENT or ORLL or whatever we're calling it, there was some additional patient work. We've kindly been able to work with our colleagues at Lakes DHB to have some additional outpatient work done over the weekend, Saturday and Sunday. Saw quite a large number of people over those 2 days, and Lakes team will come back and help us again over coming months as we recruit. Have already done one interview for that, and there's a second interview to be done, so it's looking quite good in terms to be able to recruit a second ENT surgeon and stabilise our service there. And similarly, ophthalmology, we're getting some outside assistance around that as well, and we'll be able to support our ophthalmologists and ophthalmology registrar to reduce the numbers of people waiting for that area as well.
Jim, just on the planned care production point, what was the boiler issue?
Yeah. So.
Did we?
Yeah. Yeah.
Gosh, I must have been having the zone out.
Might have been. Yeah. And just in a nutshell, the water supply to the boiler malfunctioned, which meant that the water level dropped. It picked up some sediment as a result of that, got into the system and got as far, well, we believe it got as far, we're concerned it might have got as far as the autoclave, got into the autoclave steam, might have got through the packaging in the autoclave steam to the actual instruments. And we took a cautious approach and said we can't utilise those until we've actually cleaned the whole system out and reset it again. So we lost about a week's production.
Wow, I missed that.
Yeah, I think that's about it. I'll just check. Just ED, set 1 and 2 events there. I think that's about it.
I did want to ask about, oh, sorry. No, you can't.
Can we go back to page 38, please? As my concern are the figures for ENT, and I'm not sure whether I need to declare an interest here, but the concern that I have is the number of people waiting for a FSA. If you go across the table to the right-hand side, that's over 2,000 people waiting, of which 483 are in ENT, 21%. If you go down to the number who have been waiting for longer than 6 months, 241 in ENT, of a total 468, that's 52% of people waiting for a first specialist appointment are in ENT. And I'd like to bring to the board's attention that it's an area that we don't seem to know a lot about, and I would like to have more information to see how we can get those waiting numbers down.
So I think Jim's talked a bit about recruitment and.
Yes, and also we saw 63 people over the weekend to attack that. So yeah, that's exactly what I was just talking about in relationship to plans around that area in particular. So to get an additional support to be able to really get a blitz on that. It's been difficult to secure, so we're very grateful to our Lakes colleagues to be able to make that available to us, to be able to have that level of impact in across the weekend. But it does mean, of course, that we do have to have people working across the weekend to be able to achieve that. And yeah, recruiting into the second position will also help with that as well. The other thing that we are doing is working through our GP liaison with primary care, because we believe that some of the referrals that we are getting could be in fact managed within primary care, and that we are getting people waiting for to see a RRL surgeon that don't need to and could have been managed within primary care. So that's another area. But we have traditionally had a commitment that once we have put people into our system, we will see them. But we are looking to see how we can manage better those people coming through. So there are pathways within pathways of care that we are putting in place with primary care to reduce that inflow as well.
So, Jim, across all of these areas where people have been particularly waiting for the longer than 4 months, that's the target that you would say, isn't it?
Yes.
Are these all related to basically vocational vacancies in these areas? Like, have we got are these the areas where we've principally got capacity gaps?
Yes, yeah, that ENT is an area where we've got a current capacity gap, and in fact we probably have we have had a capacity gap there for some period of time, and it has also been how we've been managing those, so we need to get better at managing those, particularly with primary care.
So that to me that kind of says with so these FSA waiting times are linked to capacity gaps, sitting alongside our budget where our outsourced personnel is just getting hammered because we're getting in locums, then we probably as a board need to be keeping a close eye on the recruitment issues in here around getting our capacity up so that we can keep our budget blowout down and our service delivery up. So that's maybe something that we can have a chat about as a board.
Sure. Yeah, so in terms of this, there are 2 candidates for us to recruit for ENT, and so then both of those are looking good prospects to be able to recruit. We also got a second ophthalmologist that we are in the process of recruiting as well. So we've been utilising, we've got 1 part-time ophthalmologist at the moment. We added in a registrar to try and be able to increase the capacity there. That's not enough, and we've been needing to go out and try and find additional ophthalmology support. That is difficult because there isn't a large amount available in the country. So we're actually going to recruit a second ophthalmologist instead, which will be more expensive, but will obviously cope with this problem of demand.
Sandra. So if our issue is one of capacity and outsourcing to cover the positions, have we looked at the cost of other use of other providers away from this area?
I mean, sending people out of town for their appointments. Yeah. Generally, the capacity is not available wherever you go. So it's really a case of, if you can get capacity, it's better to get it here so that you can see, for instance, 63 people across a weekend is much more efficient than trying to send 63 people out of town. And much easier for people as well to be able to come here. People were very good about it, obviously they want to get seen or get their children seen. So coming in the weekend was not a problem for people. So that worked well. And we want to replicate that more often to be able to dig into the numbers of people who are waiting longer than those longer periods. So those figures you've got on page 38 are already improved because of that, 63 people coming off that.
Okay, are we able to get a breakdown of those figures?
Well, we're reporting these every month.
Okay, so if you look at the number who have been waiting for FSA greater than 6 months, there are some people on that list I know may have been waiting for years. So it just doesn't give accurate indication on what's actually going on. And we're just looking at numbers and we're just looking at greater than 6 months.
Okay, well, I can give you a breakdown of that 241 as to how long those people have been waiting.
Okay, thank you.
So bottom of page 39 and top of 40, and it actually follows on. Again, I will also declare an interest, but we've got human resource capacity, and then we've got the equipment necessary for some of these treatments. At what point do we not have the machinery or the equipment required for some of the treatment times because again, we're talking years in some of these cases to actually deal with these treatments, because first specialist appointment is one thing, but you still have to do something about it. So if you can't do something about it because you're missing either the human resource or the equipment to do the treatment, then how do we address that?
Well, one of the particular areas that we know is a rate limiting step for us is theatre capacity. We don't have enough. So we did put in a bid for the government's planned care funding, or capital cap funding for that, for an additional operating theatre. We were unsuccessful at that. So now what we are doing is looking at ways in which we can reconfigure other areas of the hospital to be able to create a procedure room where we would be able to do more of the work, take work out of the theatre that's currently done there that maybe doesn't need a theatre environment, and do that in a procedure area that would then free up more space to be able to do some of the other areas here. For instance, we know that we could shift our cataract surgery out of theatre and do that in a different setting that would release a theatre and also get those people done. So there's 16 people there who've waited longer than 4 months for ophthalmology procedures. So that's just another example. So yes, you're right. It's sometimes it's actual physical capacity as well as staffing capacity that creates the problem.
So do we have the potential at all, not necessarily so much of sending out of region, but I guess inviting some use of the private space? Have we done the costings on that? I don't know. Is it something that we could do that and work on?
Well, the issue is actually having an operator, the person that actually does the thing. So you've got the combination of the two. So private space doesn't necessarily have capacity either. So that's the situation we're facing within the country around the availability of particular surgical areas like ENT. And that's another area. So it's not just first specialist assessments that we're getting support from Liaison. It'll also be operating as well to address those 42 people.
So, Jim, across all of those treatment waiting times in that table Sandra's referring to, they've all gone down over the course of the month, with the exception of surgery. So general surgery, paediatric surgery and plastic surgery. So is there a particular issue in there? Or is that just directly related to the operating theatre? Hiccup with the boiler?
The hiccup with the boiler would have had an effect, particularly around orthopaedic surgery, although it didn't really change much in that period of time, and probably general surgery as well. The areas like paediatric surgery and plastic surgery are visiting specialists, so they come on a once a quarter basis, so the numbers will go up and then they'll come and they'll clear that out, and then it'll improve again. So yeah, those ones are less, and similarly urology.
So you think that there is a link to that drop in production over the course of the month?
I believe that will definitely be the case in relation to general surgery.
I did want you actually preempt one of my questions I was going to ask. I was going to ask specifically about general surgery. Thank you for your answers in regards to ENT. I do want to support Tairāwhiti's request for just elaborating more on those longer than 6 months wait time. It's a very fair point to kind of, there's a lot of months after 6 months, so that'll be good to be able to see that. My question was actually linked between SB2 and SB5. So all the 60 plus that we saw over the weekend, how many of them end up on the SB5 treatment waiting list, and then do they end up having an impact on us not complying with SB5 on the other end?
There will be some that will then go on, will have confirmed that they do need surgery. As a result, I don't know offhand how many that will be.
It would be. I assume that after the first specialist assessment, that it'll be either these are the primary care treatments. Actually, you're all right. These are things you can do at home. These are the ones that need surgery. It'd be good to get a breakdown as to how the first specialist assessments impact our possible waiting time. So, what percentage?
Yeah, sure.
I did have one other question in regards to case weights. So I do want to note and acknowledge on the bottom of page 37, second bullet point, throughput. The case weights for the month when all cases are coded are 332, which compares to last month's total 597. That's awesome in regards to comparison between last month and this month. I did want to know if that trend kind of is the same between we can't use 2020 as an example, but say between 2019 previously, that we have a higher case weight kind of February and then a lower one kind of logically on March? Like, or do they just always fluctuate randomly?
Well, I mean, one factor in the way they fluctuate from month to month is the number of days in the month. So a shorter month has less opportunity for people to be coming through and to be treated. So that's one. Those are total case weights as well. So they're not surgical case weights or planned care case weights.
Yeah, what I'm trying to get in my head is that straight comparison from month to month. I was kind of thinking, is that also how it usually goes in 2019, 2018, that we have a high February and then a low March, a high February, a low March? Yeah, well, if you just go back, to page 32, and there you can see the sort of sawtooth pattern there, month by month variations, and the peaks there. So that will show you that.
Can I just ask, does everyone understand about case weights and the link to complexity and what it means for our money?
Well, I think I have an understanding, but if someone can elaborate, because I had a follow-up question to what Josh, which was, was sort of linked to that, was the financial question, is that if numbers are down, then how come our costs are up? That's what but if someone can give it. Oh, not very nice. If we could get an explanation, that'll be good.
Yeah, I mean, in general, it's just around, so when a patient comes in, say, with an infection, you then have a cost associated with that, and then you have a weighted index around that. So if they subsequently got renal failure, kidney failure, lung failure, all that, you added another addition to that, and then you get total weight for that. And it's also related to the admission, how long they stayed. If they've stayed, they've expected to, a normal case which is supposed to stay for 3 days in hospital, and you find this patient staying for 8 days, we don't actually get a lot more as a result. But if it stays with less than that, then it's probably beneficial from our perspective. But that then flows into that much money you get. So if you get 12 patients, 10 patients with the door, and each of them has a case weighted index of whatever it is, then you will get, say, $4,000 per patient. And if it's a lower case weight, you get $1,000 per patient. So it just means that it's the complexity of the patient and how it's recognized by the system. It's not a perfect tool, but it is useful.
Bearing in mind we don't actually get the money, we get bulk funded, so we don't actually get. Yeah. So if we do an extra 100 people at 100 case weights, we don't get extra money. Yeah.
In correlation to additional.
Yeah. Except, I guess, in planned care, in which case we do get we are expected to do a baseline out of our population-based funding, and then on top of that we've got additional case weights additional procedures, and then case weights that we can do. And then this year we've got additional on top of that to be able to do as well.
On that point, Jim, I recall that last year we lost some funding because we didn't meet our minimum number. Are we going to have the same problem this year, just from our planned care is behind, or does the government take into account, MOH take into account the fact that because of COVID there is actually more planned care to catch up on, and therefore they're not going to penalise us if we fail to do our minimum numbers?
In simple, yes, that's something that we've been checking on to make sure that our pattern of service delivery is going to meet their requirements for us to access the additional. But we do have to keep the volumes up right through the end of the end of June to make sure that we do maximise our ability to do that surgery for the population, but also to get the funding in. So we haven't, in our financials at the moment, you see, we haven't made any provision to receive that funding until we are absolutely certain that we're going to get it.
So we say what, 93.8%. Are we tracking for 100%?
We know that we're tracking for 100%. We know that gap that we've got at the moment is just is us just making sure that we've actually got every last procedure in. We're confident that we'll be able to do that. So that's not concerning at this point.
Okay. So I've got a couple of questions coming.
Sure.
So I do recall asking on a couple of occasions or more over the last 2 or 3 months around an analysis of the cost of outsourcing versus if they were in-house, just to understand the differential between. Has that come back? Have I missed that?
Yeah, it was at FRAC about a month ago.
Okay, that's right. Okay, thanks. And the other question is in relation to the SAC 2, the review, SAC 1, SAC 2. Let me just find the page. Page 43, top of page 43. When are we expecting the review back? See, the report was done on the 12th of March. That has been sent to Waikato DHB for review.
Which one is it? Sorry, Tony?
SAC 1 patient out event.
Oh, yeah.
When is that response due back? Bottom of page 42, top of page 43.
Don't know. I'd have to find out for you.
Could you please?
Yeah, sure.
That is all my questions. Yep, that's me. Thank you.
I was just overall looking at all those numbers and hearing the discussion today. Thank you to those that queried. Jim, does that have what's the impact into the hospital's reputation with respect to waiting times? Do people stop waiting and just say, I'm not going to show up and I'll go somewhere else or just not show? I don't know. I just was wondering about how are we affirming that it's based on very good reasons. Like we are absolutely trying to do what we can. So we're confident with those numbers. Are we expecting them to get worse, or in the notion of more people needing to see an ENT in this framework in time. I just am cognizant of homelessness and home issues that can lead to health issues in this current climate we're dealing with. And so the numbers we currently have seem really high, but the hospital's comfortable and confident we're dealing with those. But where is it going to get better? Or we're going to see, how certain are we in this uncertainty? Respect to that, and as I said, our hospital's reputation, respect to all the issues we're facing. Where does that sit in the conversations?
Well, I'd have a look at page 39 and have a look at the graph there in the middle of the page around FSAs.
Yeah.
That's people, the top blue line is total numbers of people waiting for a specialist assessment. So you see that that's steadily increasing. So there's more and more people being referred in from the community to see a specialist. And then the, I think it's orange or red, whatever it is, I'm colourblind, line below that is hovering around the 500 mark of people who are waiting longer than 4 months to be seen. So you can see that while we're putting in a lot of effort and we managed to turn the tide after the COVID-19 effect and got back to pretty much the same as it was before COVID-19, we are not making a lot of headway at getting backwards from that round about 500 people mark that are there. So we're getting more and more people in. So we're keeping up the pace of more and more people coming in, but we're not being able to turn the corner and go back down the other way, which is what we want to do, and obviously what the community wants us to be able to do. Now, to effect that is going to take more resources and better use of resources that we've got at the moment. There's a lot of that capacity that we're able to apply to that is outsourced, and the difficulty in that is that every DHB in the country is chasing the same resources to be able to do, attend to the same thing. So government has put a heap of extra money into the health system to try and deal with this, and some of that will undoubtedly flow through and help us to improve. And also, as you know, government has also done a review of the health system and is poised to make announcements about the outcome of that review report in the next month or two. And that will, I think there's some expectation that may have an effect in a medium term. It certainly won't have an effect in a short-term basis to be able to do that. The health system is extremely busy, and there's a lot of other things that have happened in the last 12 months or so that have contributed to that as well, and is certainly happening at the moment with our number one thing at the moment to vaccinate people against COVID-19.
Yes. I guess I appreciate it's said something about doing something on the weekend. So you're looking at other ways and means to do these numbers. So, and I don't know whether people know that, you have work is going on to try and mediate, or, to get to a point of lessening numbers needing to be seen. So I appreciate that work's going on. But of course, as you say, lots going on in the health sector. So
I think the other thing too, Meredith, is the workforce pipeline.
Yeah.
There is only so much workforce in New Zealand, and everyone all DHBs are competing for them, and all the vocational workforce wants to be able to do private, and the additional challenges of recruiting internationally at the moment. So, as a whole of system, we're actually faced with some really quite significant challenges across New Zealand.
So can those...
sorry.
I think you raise a good point, Meredith, in that we know the issues. We know where the problems are. The people who need to know are those on the waiting list. And so are we communicating in the best way possible to ensure those people that, yes, we are looking into it, to look after the reputation of this DHB in the community, because there are times when it could be better based on better communication.
So you mentioned the private system. Do they have access to this pot of money as well, or not? Or are we competing with the private sector for this funding that's been released, or are you talking about?
Plain care funding. No, well, you can. DHBs can use private facilities if there's capacity available.
So the private providers
you don't have to do it yourself. You can outsource it if that's the solution. there's no conclusion to that at all.
So the private providers have also got access to this extra funding?
Not directly, no.
Not directly, okay, so that's what I'm trying, so it's purely for the public system?
Well, it's through the public system, yeah.
Right.
It's public funding through the public
But
system.
could end up in the private space because
it could
it's a resourcing.
Yes, if there's capacity, and for instance, our ophthalmology that we've got Lakes are providing us with ENT, but our ophthalmology is coming from the private sector. Our additional ophthalmology is coming through the private sector. So yes, we are utilising the private sector where there's capacity.
Yeah, I was coming back to Meredith's comment around those that can't necessarily afford to go into the private sector for something that's particular.
Well, they don't. Where we're paying for it.
Yeah.
Publicly paying for the private sector to do that work.
Yeah.
So they don't have to pay themselves.
Okay, Tony.
So on that graph, Jim, between June 20 and September 20, there was an almost 30% reduction. Why did it flatline? I mean, it was an amazing trajectory bringing those FSAs down. Obviously, something's working right for 4 months, and then it's just plateaued and it's slowly crept up again. Can you maybe not have the answer here now, but I'd love to know what went right for 4 months and then what's seemingly not going right anymore.
The lines, in terms of the orange line, the red line.
Yeah.
It's what you're seeing there is the Christmas New Year reduction in services. So that's why it's gone up a little bit there, and it'll come back down again now that we're back. There'll be a little bit of lost capacity around when the boiler when we had the problems with the autoclaves for a week. So that's what you're seeing in that little bit of but I expect that to come down again now that we've got this additional work going back on again to keep on moving that down. But it's not easy to get it down.
Okay, just one more comment, someone, and then I think we might wrap this part of the session up.
I can just add to Jim's point. That's all right. I'll be working with Jim in terms of looking at a workforce strategy, in terms of making sure that we've got the workforce to deliver the outcomes we want for our patients. And it is important that we get our SP 2 and 5 compliance up, and some of that might be what specialists do we need within our DHB and what we need to outsource, and some of what do we need to put to the private sector. And it's an issue that, as I think Kim raised, it's an issue across pretty much most of New Zealand. Even where I come from the Auckland area, we have people waiting for cataract surgery for quite a long time in Middlemore. We've got a lot of capacity in Auckland. Auckland had 2 of them, one of them left, and suddenly there's a big gap there. So it is across the thing. But we, as a DHB, I guess it is important that we actually look after our population, and whether that is by having staff within our workforce, which is probably the best way of doing it and delivering that care, or whether it's by outsourcing a small portion of that. But we'll work on that over the next month or 2 and then come back to you.
Enroll.
I was just going to say, just on the workforce issue, so it sounds like there are greater financial incentives and rewards for those specialists we're looking for to work in the private sector than there is to be in the public sector. So if we're putting a particular lens in terms of addressing equity issues, the greatest issue to be addressed is to be able to attract specialists to work in the public realm. So I'll be interested to work out, because that sounds like that's a pipeline issue. National pipeline issue. So.
Sure. And that's where, we have done a lot of work to try and secure the pipeline here in terms of, for instance, introducing registrars here as well, to be able to train here in Tairāwhiti, and, with a view to them then moving on and having more within the workforce that may come back here once they've got their final qualifications. But we're struggling with that as well, because those positions aren't funded through health. There's 2 positions that are funded through Health Workforce in New Zealand, but we've got about 15 now. So that's another example about where we've tried to do something about that. That will eventually improve. But I just looked at the statistics recently around DHB's recruiting, and the top group of people that the DHB is trying to recruit is psychiatrists, bingo. The next group is anaesthetists, bingo. And then after that, there are ENT et cetera, et cetera. So all of the ones that we are particularly wanting to recruit are exactly the same ones that are in high demand around the country, and we haven't trained enough of as a country.
Okay, thank you, Jim. Thank you very much. So that's our segue to you, Craig, for the financial report. And I did have one question on Jim's report that perhaps you can answer in the context of the financial report, which was around Jim's leave discussion. And what I wanted to know was, does that get revalued with changes to MECAs and that kind of thing? Okay, if you can address that in the financial report.
Thank you, Madam Chair. Yeah, I was probably going to just touch on 3 key points. So just revaluation. So on page 49, we've got a little summary at the bottom of the consolidated P&L. With our sort of unbudgeted variances, see the leave liability in there. So that's 900K. That's increased from the start of this financial year to period 8 in the end of February. Of that, 440 is for our leave liability, and 460 of that is for our CME. So that's leave not taken throughout that year. Jumping up to page 53, just touch on capital expenditure. Year to date, we're 519,000 over budget, 1.12 for BAU capital, and 1.6 adverse for our carried forward from property year. The summary there on the top, just above the table there, explain the 1.6 adverse. It's sort of winding down. We can see for the month we're 382K favourable, 383K favourable. Favourable to budget for the month. So we have to spend that amount during the month. Cash flow is holding up considerably well. 264 million in the bank. We've got an application down to the Ministry of Health for 1.1 million. That's reimbursement from our 3 million worth of capital for the demolition of the mosque and capital spend. To provide them with some quality assurance reports. Happy to do that through our internal auditor. Expect those funds early in April. Over the forecast on page 54. So current forecast has shown that we are tracking for an adverse to our 4 million deficit budget by 3.2 million. Our BAU is currently sitting at 6.2, so it'll be 2.2 million off budget for BAU. The big increase during the month for that is 1.152 million with the testing that's going to the HOs. So our planning and funding team have worked hard to try and mitigate that cost, but it is a cost that the BHB will be incurring. One-off expenditure, so we've got the income coming in there. So that's from our donations from the Ministry of 423K, around 400,000 from proceeds of sales from our 2 properties, one at Matuai and one at Tikaraka. Have you taken any other questions or comments?
Questions? So I do have a question. So the minutes of our last meeting said that we've flagged the deficit revision to the Ministry of Health, but the minutes don't record it at 7.1 million. So has this level been flagged?
Yes.
Okay.
Yep. And also the reason for it.
Yeah.
Specifically around those community COVID costs, and the Ministry are aware of that and have, they've noted that to be listened.
Yeah, so that's a conversation with Jim and John Hazeldean and myself with Raj and the Ministry, and these go through our monthly templates as with good explanations as to the deviations. Phone calls come pretty quickly if there's not enough detail or they want further explanation.
Gav, you've got an issue.
Oh, it's just noting that the COVID component's part of it, but the earlier conversation, RE outsourced personnel far outweighs the cost of the COVID in terms of their forecast. So just, in terms of things the board can focus on, what we can do to understand and resolve that component of the cost.
And I think that's probably the thing that our CMO has flagged that we really need to hone in on is the workforce and the recruitment dimensions.
Yep.
Mhm.
Any other questions?
Can I, Madam, can I ask just something on, just on page 54, if I've got it right, under that number 10, risks year end. Can you just explain that to us, please? Some of those figures have got a negative to it, but some haven't, and I just don't know if that's a positive variance or a negative variance.
Thanks, Mark. Yeah, so that's a negative variance. So we've got risk to the 3.2. We're currently seeing between, well, we've got 600 and 900 in there. If we add in our soft accrual, so once we're currently with our soft accrual and Holidays Act 1.8 million, we take out the Holidays Act of just over 800,000, that leaves us $1 million. At the end of last financial year, we had 582,000, which is our sort of period 13 adjustments. So going from where we landed on year end, we have a number of wash-ups, Farm Act, IDF outflows, accruals that we haven't captured at June. So we take the delta between where we finished last year, 582 wash up, and the million. That gives us another 380,000 upside on that number. So we're saying we've got a potential risk of cost coming in around 220 and 520,000, based on not knowing what the impact of IDF outflows are and final Farm Act wash-ups.
Sorry, Clay, I just don't know where those figures are, 200,000, 520,000 on.
Yes, sorry, Kim, so I've added in the additional wash-up, so you won't see all you'll be seeing is the 600 to 900. I'm saying that's further improved by the delta between, if we take our last year's position, so the wash-up between where we finished in June.
So can I ask probably the question that I was asking about very directly and for a layman's response? For the equity investment fund, that negative 500,000, does that mean that we are only now anticipated spending 1.5 million of the equity investment fund? Is that what that actually
in those figures, we've got all of the equity investment fund being spent. It's unlikely we'll spend it all anyway, because we just haven't got the definition around what we're going to get.
So
but it's included in spending it all is in there at present. And
so
not in this.
We're forecasting to spend it all in there, but this risk to year end is saying actually it's likely that
we won't spend
500,000 won't.
Yeah, half of it won't get spent.
Jeez.
It's $1 million this financial year, but on 200 ongoing. It's $2 million ongoing.
Yeah.
So just to follow, because that's exactly where I was going with this, Kim, and that equity investment fund. So that equity, we've created that fund, haven't we? That's not extra money coming from somewhere else.
Yeah, that's right.
And so the question then is, so are we, because of that potential wash up in the negative of 500K, does that mean that we reduce our commitment to, in this case, inequity? Is that what that translates to?
What that's saying there is that we may not spend $500,000 of our allocated $1 million that we allocated for equity investment, and therefore, but at the moment we are in our financials saying we are going to spend, but we may not. Yeah.
Yeah. So that's. I mean, I'm just highlighting in my mind what that signals for the board is a reduced approach to inequity, basically. That's what it translates to, though, doesn't it?
Not
really. There's 500K that we're not going to spend on reducing or getting rid of inequity.
Yeah, but we've been going through a process around working with iwi around how we will spend that money.
Yeah.
And that is the key. Yeah, so we haven't made decisions on that by ourselves. We are in a process to make those decisions. We've made decisions to spend half of it, but still the other half to go. And at this rate, even if we started today, we wouldn't spend all of that money.
I think that's an important understanding for all of us, and appreciate the need for sharp definition of how new money is going to be spent. So hopefully as we move into our next financial year, we've got those processes in train for the ongoing work with our partners about where to target equity specific investment.
Sure. So we've done a lot of that work now in terms of we know the 5 areas that our partners here's where it should go. But it's the code think. We've done that. We haven't done the code design about taking that down to the next level. So that means this is what we should be doing, and then co-implement. We certainly haven't done a lot of that. The other thing too is I think it would be wrong to suggest that we haven't done, that we've done nothing about equity improvement, because there's many other examples where we have that aren't related to that investment fund that we have implemented this year.
So if I could, though, I'm not suggesting that either, Jim, just to be clear, that's not what I was saying. What I'm saying there is that it's important for the board to understand what that line meant. It just looks like a figure, but actually it translates into a reduction of that amount in that area. But I get your point around working with iwi partners in another direction.
We have made some progress in that space. Significant progress, and in fact, while we haven't committed the 500 that we won't spend this year, we've got a different 500 that we're investing.
That's the health.
Te Herenga Hauora.
Yeah. Okay, so thank you, Nga. I think it's given us all like a practical understanding of what that particular line means. So if there's no further questions on the financial report, we don't have any items from subcommittees to report through to the board from their public sessions, unless Josh or Hiki, there's anything you particularly want to raise from the committees. Okay. The COVID vaccination update is at page 57. And just as you run through this, Jim, or if anyone's got any questions, I'll also just outline the questions that the Minister has signalled in February that the board needs to be ensure that it's abreast of the COVID thing, so ensure that we are asking the right questions.
Okay, so in a short number of sentences, we have finished our work around border workers and their households pretty much. There's still a bit of still some people coming forward that we will make sure that they're vaccinated in the next phase. So we're on to tier 2, start 12th of April. Tier 2 is frontline workers, health workers, and associated as well. We've got our planning around that well advanced. We are starting April 12 with Hauora Tairāwhiti staff. We've made the decision to vaccinate the lot and not try and pick out who are the frontline people and who are not. Just more efficient and easier just to get the lot done. So we've got 2 weeks mapped out. In those 2 weeks, we estimate that we will be able to give roughly 2,500 doses. So that's enough to do all of the, pretty much, I think, it's pretty close to all of the frontline workers in Tairāwhiti that we could do in those 2 weeks. Our main issue around that will be getting them there ready to do it. And we know that we will need to do some of those people in other locations, such as at Te Puia, for instance. And we've got, at the moment, 30 vaccinators on our list of people. Yeah, it is 30. I counted them up. Yep.
Have they all done the IMEC training?
They've all, those ones are all ready to go. And we're going to need roughly about 30 to 50 to do the full amount. So those that we're going to back to Patama room to have that set up. just makes it's very efficient to get people through there. So there will be a need for some people to travel to here to be vaccinated. We will be doing that 6 days a week.
Into late Thursday.
And into the evening to be able to try and get as many people through as possible. And as I say, the main thing will be to have people booked and steadily coming through, because we'll have the team there ready to go and do that. We'll have the doses, everything that is required to do that, and then we will be able to complete that. Phase 2, we've got St John to do, but we believe the police and Fire and Emergency New Zealand are getting theirs through their own organisations, so we don't have to do those. And then 3 weeks later, again, the corresponding 2-week period to do the second dose for all those people. So we vaccinated over 600 people in Tairāwhiti now, probably around about a third of those people are fully vaccinated, had both their doses, and the others will be done over the next week or so and complete that. So we, after tier 2, we will be around about 10% of our population vaccinated. And then after that, we've got the staging that we have to do. We peak at 3,600 doses in a week in the last week in July. That's in tier 3, so that's pretty much the rest of the population that we have to do there. So again, we believe that we will need 3 teams of vaccinators and support people working to achieve that. So we'll have a team here still in Tūranga, possibly in Potamarun, but maybe another venue, and then a team out on the road out west to mock that up, and then up the coast, township by township. Talking with iwi about that, that's probably the best approach to do. It worked very well with swabbing. You remember that we went to towns and were able to swab virtually everybody in the town in a day, and that's what we're thinking that we'll try and be able to do with this as well.
Couple of days maybe, yeah.
Can I ask which Peter's age here in?
It's in 2, but we're also we're asking every other health service worker to come here with, we may actually end up doing the staff and the residents at the same time. There is some challenge with thinking that through, because if you're bedridden and you still need an RN to oversee your recovery, there's actually quite a significant bit of logistics to be undertaken there. So we haven't landed really on where that's at and how much support we might need.
So just before we go into questions on the report, just to highlight the things that the Minister has indicated the board should ensure that it feels it's abreast of. So one of them was really about the workforce and logistics and delivery preparedness for the border workers. So that, to my mind, is now shifted to for the wave 2.
Yeah.
To understand what level of engagement has happened with our wider health sector and particularly our iwi providers, and ensuring strong equity focus on our planning. So if we can just bear those things in mind when we're thinking about the questions we want to ask, and also the reporting that comes through. And then just the other thing is, so this vaccination sort of rollout, so Jim updates me on a weekly basis in our one-on-one catch-ups. I'm really conscious that we're asking for a lot of extra stuff from our staff at the moment. And so I guess I just want to test, is the board happy with getting a monthly update and maybe having the committees updated the week prior on any emerging issues? Okay. Because I really don't want to have to ask for a between month an intervening sort of formal.
I guess unless there's something really.
Unless there's something, if there's something terrible, Jim will raise it and we'll run the flag up, and if need be, convene our small group of me and the committee chairs to do anything that is immediately our sort of little COVID committee.
I think the sort of key issues at the moment are around, releasing those 30-odd people or more to be able to take part. And also, we're going to try and get as many people we've got a core team of public health nurses who've been the absolute champions of this all along. They deserve a lot of credit for the effort that they've put in to date, and that's why we're starting on the 12th of April, because we're giving them a little bit of a break between the two. They will be the sort of basic core of our teams going forward for this, because they are well practiced at this now, and have got it very efficient. So they will be supported by other Hauora Tairāwhiti employees, and also already we've got support from our community partners to supply their vaccinators as well. So that's why we were able to build up that team of 30. We want to get that up to 50, so we can bring people in and out and spell them, because it's quite intense, just moving from one person to another as they come through that virtually a production line for vaccination. So that's one factor. The other factor is venues. We have to have a venue that really works well. Potama Room does, but if you can hear sort of a screaming sound, it's because people have been had all their meetings kicked out of the Potama Room for 4 weeks, possibly going to be 6. If we need to use it for another week there, and so there's a lot of.
It's not going to be big enough for 3,600 in a week.
No, well, with the 3,600, we can do about we can do probably half of that in a week in that place, and then the other half will be done of the other two teams out and about. And but the beauty of a facility like that, and you'll probably have heard in Auckland they've set up facilities as well, there is just the speed and efficiency you can have with getting people through, going to and we're absolutely going to do it, but don't get me wrong, but going to a smaller community, setting up, having that getting people to come there, is you don't get us through as many people in a day. And when you've got 38,000 people to vaccinate by the end of October, and 2 doses, so that's 76,000 doses in that time. And of course that's proportionately the same for large DHBs. Have got much larger numbers to do. So it's a very big logistical exercise. So the other thing around venues is that it's because we've got a single vaccine strategy, which makes a lot of sense. It makes it much easier in terms of planning and what you have to do. But that vaccine, two dose vaccine, it does have those requirements around temperature control. So it makes it not quite that easy to be able to get up to Tairāwhiti and just roll into town and do it, and find a place to do it.
Yeah. So I guess my question is around, say, vaccination by community in the coastal region, and then key sites out west. What's the difference between?
No difference. Just
no difference.
So it's really one day.
Sure.
That's
sure.
the thing.
Yeah. Because the other question I did have was around as the science continues to evolve and support the vaccination process, and I'm thinking more of the vaccine hesitancy. Are we being really proactive about communicating the good science behind the vaccine as it becomes proven? Because it is a wee bit, I think I use your term of building the plane as you fly it. How do we best get those messages out?
The comms, probably will tend to pony on this really, but the comms are very much a ministry process.
Yeah.
It's nodding her head.
I was just going to say, I was on 3 times a week we have a Zoom with the other DHB managers and either all the government comms leads and the ministry comms leads. So there's been a lot of collegiality, a lot of sharing of resources. I mean, very much at the moment we're focusing on group 2 and comms, we call it groups rather than tier, just to try and keep simple in groups. But on tomorrow, they're actually going to be talking, we're going to have the agency joining us that's working with all the government for the more public rollout of the campaign. So the public rollout is still a little bit further away, and that will very much be focused on sharing the good news simply and understandably, and on addressing vaccine hesitancy. But like I said, at the moment, it's very much about engagement. So the concept about engagement with the target groups and rolling out to group 2.
So I think, Sandra, with this stage of the pandemic that we're in, the model is still very much the same. So the ministry is establishing and leading all of the parameters around things like vaccination priorities and vaccination comms and that kind of thing. Locally, we have been working with iwi on particularly comms related to their communities and how they can support reaching particularly those vaccine hesitant.
And the ministry has just rolled out some funding for iwi to support those as well. So we provided some funding for iwi, and then
so that's more on to Māori providers.
Yes, sorry, yeah, sure. So we provided some funding out of our resources for iwi, but also the ministry have gone to provided funding to providers, iwi providers.
They're still working through process, so it hasn't actually gone to them yet. They're boosting the ability for Māori providers to work closely with the vaccine rollout.
And just on the vaccine, that analogy about building it while you're flying doesn't apply to the vaccine.
No.
The vaccine is being developed up in the same stepwise process. It's just that there's two factors that have made it different. Well, three factors really. Billions of dollars of input from around the world to get the vaccine done. So no sort of doing it on a shoestring, money. There's millions of people with the virus currently, so that it's not like usually where you've got a small number of people with this particular disease. So you have to try and do a lot of time to try and find out if it's effective or not. This one is lots and lots of people available to test it on. And also a lot of the production, because the vaccine has been developed, production facilities and things like that were being developed at the same time. So normally it's sequential. You do this and then that and then that. It's been able to do many things at once. So yeah.
And it's actually that messaging that I think a lot of people are looking to hear.
Sure. Yeah.
And global cooperation.
That's right.
Yes.
Exactly.
Yes.
Exactly.
Yes.
Yeah.
Yeah, there was a couple of things. One you've already touched on, and I kind of wanted to point to it a bit more. And we did bring this up when we discussed this in Hiwi, that it was around freeing up the staff that would be doing the vaccinations, that they already have their own work programs. Sure. and things like that. And I guess for me that kind of connects into the funding of the positions. Absolutely agree with how we're funding the rollout of this moving forward, but is there an indication of a phase 2 of funding in order to be able to cover the shortfall? Because if there isn't, it's kind of our local services that are giving things up in order to do this.
What we have is, at a national level, the pricing is being developed, but what we have is similar to our testing regime. Get on and do what you need to do, and this is the minimum staff set you need to have with an expectation. We've got an agreement that doesn't have any flaws in it. So the expectation is that we would go ahead to do the things that absolutely are needed to be done. We fully expect to be reimbursed for them.
Yeah, the minister has been clear, money is not a barrier to vaccination.
It feels like a blank check, but it's not.
Well, and that's why I asked, right? Because there's assurance, but being there, but when it comes down to brass tacks, the conversation might be vastly different.
So vaccinators are absolutely needed for the program. Coordinators, administrators are absolutely needed for the program, and that's the core base of your staff workforce. So where we're asking people not to work in their BAU job, we need to have a discussion about whether we can put on hold. So for example, in Tairāwhiti House, are there some areas there that we can hold off and negotiate with ministry won't be delivered this year? Are there some areas, and if failing that, would they be happy with receiving funds to backfill those roles? On a like-for-like basis, there's no boosting on any of those. There may be a little sweetener that we can find to enable the providers to see a pathway, but there's no boost in any of the funding like there was in testing, for example. So they overdosed costs and prices in testing for the first round. Yeah. At this point, I mean, we're all pretty much aware that while we could have a blank check, we actually just need to get people on board for what's needed.
Yeah, absolutely. Yeah, and I imagine it will be the same across the whole community. We all want this to want this to happen, but sitting at the table is, I did have the concern about what we're not going to deliver in order to deliver this very crucial thing. It's like this, not delivering these also very crucial things in order to deliver this globally very crucial thing. It's kind of
I think your concern is particularly valid. It's not just the money, it's the backbook.
Yeah, exactly.
It's a human resource.
If we don't have people to fill roles, we will need to have that negotiation at centre, because actually the country in larger areas, they have more access to a range of different facilities that could deliver vaccines. So a large general practice might be able to do it in a different place. A large pharmacy might be able to do it in a different place. We actually don't have that.
Can I ask, have we looked at final year nursing students?
Yeah.
Yes. Do IMAP?
Yeah.
Yes.
Yeah. So we've got a team working on the who could, and we have a pool of people who said they would like to help. How do we fast track them to get into a training program that sees that? Jim's just seen the latest list of people who've been through the whole process. We had many on board already, but they also need to be doing their business as usual. So out of the 19 public health nurses, 6 are coming out. Out of the 15 that sit with Tairāwhiti Health, 6 are coming over. It's negotiating actively from Ngāti Pro. We've got 1 to work with that because they don't have a big workforce. So it's just how do we backfill?
Yeah, okay.
And what do we need to negotiate if something doesn't happen? And I think the ministry is open to hearing that negotiation, because actually we've been doing BAU plus for close on 18 months now.
Yeah, absolutely. Thank you for that. My second thing was in regards to rolling out the vaccinations. I know everyone's really quite conscious of getting the exact amount of doses that we need out of the vials, etc. And just as a note, a smart friend of mine from another DHB said that they had like a temporary kind of call list that if anyone did fall off.
Same, exactly. That's why we've done, in those over 600 people, we've done quite a number of those people are frontline workers here, frontline workers in general practice, frontline workers in iwi providers already. So those over 600 people are not all border workers and their household members. There is a number of people in there that were on that call us if you've got doses left over group. Yeah. So yes, GPs are in there. Yeah.
Amy,
conversations.
Could I just say one more thing?
Yes.
We are in our country, we're in a different situation than many other countries. You have got active disease in the country and people are dying in large numbers. And you just need to listen to the news and hear how many people are dying in some countries. We're not in that situation. We've been able to avoid that situation by the hard work of our country, the team of 5 million, et cetera, et cetera, et cetera. So we have to be really mindful of the fact of the devastating effect if that virus got into this community in Tairāwhiti. We know what that would happen. We've seen it in other countries. We know what happened in the flu epidemic in the early part of last century, and how many people, particularly in Māori, died, and the fact that Māori died disproportionately, even with the 25 people that have died in our country. So we just really need to reinforce to people that it's not a case of, oh, well, never mind, it's not here anymore, and we can just carry on living life as if it's, we are one step away from, people getting into our community and causing a disastrous result. So we just need to keep that in the front of people's minds in terms of here's a way in which we can help ourselves, our families, and our community.
Have we had any staff to date that are registered
or reluctant to take it up?
I've not heard of any. I don't. I'm not seeking out people to say, what do you think? But I've not heard any staff members that have said I'm not going to get vaccinated.
Okay, so
that may be possible.
I'm just going to give a pause to this one for a bit.
Yeah.
We've got the Cognitive Institute zooming in from Australia at 11. So we're just going to pause this one, take a quick 5 minutes if people want to grab a drink of water or go to the loo, and then we can pick this conversation back up after the Cognitive Institute. So they'll be in 6 minutes' time.
Staff vaccination. Top the country on the table.
You meet many pregnancy or such that are reluctant.
Yeah, just another thing to add to in our spare time.
Yeah. I think I've
man.
I've managed to nail the one pager.
Yeah.
So looking at that this afternoon. Because you can do it on a.
Yeah, I think a one page would be good. Just.
I mean, it's not complete. We're looking at something just as something. Who had some.
That'll add to it. Overarching.
We'd be looking at it and saying.
It's an action plan. It's not.
It's got to, like, there's so many issues.
Yeah. It's a plan, yeah.
Doesn't seem to be that.
And to deliver.
Feeding the kids and, like respect to just all the ugly stuff that goes on. And then also some cultures can just get to protect themselves from.
That's just one thing.
Obviously, other countries.
Oh. All right. Yeah. What
Can you hear us, Holger?
Yes, in the PN.
Mark O'Brien.
Oh, he's just got his on mute.
Is that us on mute?
No, we're not
No,
on
we're
mute.
not. Hilbert, can you hear us?
Yes, I can.
Right.
And Mark.
Is everyone in? Yeah.
Good morning, everyone.
Kia ora tātou. Welcome. Welcome to those particularly who are joining us from abroad. Thank you very much for joining our meeting today. I'm Kim, I'm the chair of the board, and we've got the balance of the board around the room. I'm just probably going to very much hand over to you to introduce yourselves and provide us with the update of the Institute's work with us.
Thank you very much. Good morning, everybody. My name's Mark O'Brien. I'm the Medical Director of Cognitive Institute, and thank you very much for the opportunity to meet with you today. I might get my colleagues to introduce themselves as well.
Sure. Morning, everyone. My name is Shannon Harbinson, and I'm the Client Manager at Cognitive Institute. So I work closely with Hilbert and the team on the Speaking Up for Safety and PPA programs.
Good morning, everybody. I'm Kirsten Dyer. I'm the Senior Clinical Educator with the Cognitive Institute and provide some background support for the organisational readiness, and I'm one of the educators for our education programs.
Kia ora, Kirsten.
Hi, so I'm Hilbert. So I've been tasked from the Hauora Tairāwhiti to run the PPA project and the implementation thereof. So I had the privilege to spend some time with key influencers and people within our organisation, and also spend time with Shannon and Kirsten on the PPA or the cognitive edge side. Yeah, so that's me.
Thank you. So it would be useful, Mark, if you could provide for the board just a quick overview of the program that you've been running thus far, just to remind us of what it is and its genesis and that kind of thing, and then provide us with the update that you're wanting to brief us on.
Terrific. Well, thank you very much. And I will share my screen, so hopefully people will be able to see it. Just share screen. I just checked that everyone can see that screen, building on our Speaking Up for Safety culture.
Yes.
Yes.
Yeah, thank you very much. Well, thank you very much again, ladies and gentlemen, for the opportunity to talk to you about the program. I know I had the pleasure of meeting some of the board a few years ago when we were discussing implementation of the program, and congratulations and thank you for the work that you've done in this important area. For those of you I haven't met before, just by brief introduction, I'm Mark O'Brien. I'm the Medical Director of Cognitive Institute. I have been the medical director for 21 years, and I, along with my brother, co-founded the Institute in the late 90s. And our aim was to really provide a platform to work with healthcare professionals and healthcare organisations to make healthcare a kinder, safer and better place, with a particular focus on non-technical skills. So helping clinicians and those at the coalface of healthcare to address any challenges they may have around communication skills, leadership, teamwork. So it's been a wonderful part of my professional life. I was originally a rural general practitioner, procedural general practitioner in rural Queensland, which is in fact where I'm coming from today. This is I live about 2 hours southwest of Brisbane in the mountains in the Great Dividing Range. And since COVID, of course, this has been pretty much home. Previously, I was on an aircraft most of the time. It's the Speaking Up for Safety program and promoting professional accountability program has been an important part of our work over the last 5 years. And I'd like to give you just a quick background to that. It's also, if I could ask a little personal indulgence, it's quite a significant day for me today. This is actually my last official function as the medical director of Cognitive Institute. So feel very honoured to spend it with you. I'll be retiring tomorrow as medical director of Cognitive Institute. As some of you may know, I'm a board member of St John of God Healthcare here in Australia, but also I'm very excited to take up the position of the new director of the Healthcare Leadership Program at Oxford University. So a big change for me. So I think I've given this presentation a few times, but it'll have an extra poignancy as I do it for the last time to my esteemed colleagues on the other side of the Tasman. For those of you who don't know Cognitive Institute, we are a Brisbane-based organisation, but we have delivered programs around 18 or 20 countries across the world. And each year we have tens of thousands of people do our courses across the across the UK, Africa, Asia, and Australia and New Zealand. But the Speaking Up for Safety program and the Promoting Professional Accountability program has seen us grow that number quite significantly because of the demand and interest in this program. This just gives you a quick idea of the geographic spread of our work. You'll see that even though we are Australian based, a large part of our work is actually in the UK, South Africa. And we're always very proud to say that we have the highest number of people per head of population do our courses across the world in New Zealand. So I think I've had the privilege of being to your country. I calculated during my time at Cognitive Institute, I think I've been to your country about 125 times. So that's been one of the great professional joys of my role. The aim of the program is to address this gap that I've seen, no matter which country I work in, that we've done an incredible job in my time since I graduated as a doctor in improving the processes and systems that lead to high reliability. However, we have made some progress, but nowhere near enough progress in addressing some of the people issues that are absolutely essential for high reliability delivery, whether that be in healthcare, aviation, the nuclear industry, manufacturing. You can have all the best processes and systems in the world, but if you have a phenomenon where a small percentage of people choose to behave in ways that are very dissimilar to the vast majority of people in healthcare, this small group can actually undermine your culture. It can actually lead to bad practice, and it can lead to, most importantly, unwarranted variation in the delivery of care, which is absolutely toxic for when it comes to patient safety. And just to give you some ideas of the metrics, and I do know I have presented to some board members before, but excuse me, there has been quite a lot of significant research come out since I would have last presented to you. This is from the Grattan Institute in Australia that came out in late 2019, showing the cost of the variation in healthcare outcomes simply around this phenomena of variation in the way people come to work and the way they conduct themselves. And the numbers are extraordinary. That we have, to put it in lay terms, essentially, if you come to an Australian hospital, if you go to our top 10% of hospitals, the chances of you having unavoidable harm are dramatically reduced. And I just want to hasten to add the top 10% does not mean large teaching hospital in a city. Some of our large teaching hospitals have some of the most toxic cultures, and some of our small country hospitals have the most exemplary cultures. And the numbers we're talking about is 1 in 100 Australians each year, not 1 in 100 who are admitted to hospital. 1 in 100 of all Australians each year have a complication from healthcare delivery that they wouldn't have had if they'd gone to one of our top 10% performing hospitals. And let me hasten to add, as I'll make the point again in the next slide, this has nothing to do with technical competence. There is some small variation in technical competence between clinicians, but the degree of variation in technical competence doesn't go anywhere close to explaining this level of variation. This is variation in the way people behave at work. This is the way that variation in the way they communicate, variation in the way in which they interact with their colleagues that in fact can lead to serious underperformance and danger. This also came out probably since I last spoke to you in late 2018 from the International Collaboration on Health Outcome Measures. And again, staggering levels of variation depending on which hospital or which service you go to. And again, these are not underperforming health systems. If you look third from the bottom, You know, most people will acknowledge German hospitals as cutting edge orthopedics, and yet your chance of needing a second operation over the course of your lifetime, if you have hip surgery in Germany, varies by 18-fold, depending on which hospital you go to. Now, the 5 or 10 or 15% variation in orthopedic surgeons' technical ability does not go anywhere close to explaining 1800% variation in outcomes. And this is all about non-technical performance, about the way people work and the way they conduct themselves. One of my colleagues at Oxford, Professor Charles Vincent, excuse me, I'm so sorry. One of my colleagues at Oxford, Professor Charles Vincent, who is the Professor of Patient Safety and Quality at Oxford, when I consulted with him when we were establishing this program 5 or 6 years ago, made this comment to me that the way you can tell whether your culture is on track is whether you have a speaking up culture. And speaking up, not just to prevent harm, but speaking up to encourage a harmonious workplace, a workplace where respect is a predominant feature of and noticeable to anyone who enters the space. This is the program logic that I used in trying to put this program together as a package 5 or 6 years ago. It's similar, if you like, to a lean type model for, say, process transformation, but this is about cultural transformation. And healthcare across most of the Western world sits at level 3, which is a systematic level. And this is, you know, essentially where we write lots of policies, we collect lots of data, we produce lots of reports to the board. I'm sure you see as many reports as board members that I do that have lots of data and lots of dashboards. And we're essentially just documenting and analysing what we do. The cultural transformation that we're trying to drive with this program is to go to the next level, where we are much more actively and aggressively trying to prevent problems from happening rather than documenting and analysing them when they do. And the last 3 words there, comfort speaking up, reflect Charles's view as well, that if speaking up culture is absolutely critical. The analogy I often use is aviation. Aviation had probably a level 2 or level 3 culture 35, 40 years ago. They've done a lot of work to make aviation probably one of the safest human endeavours you can be involved with. But they had huge problems around speaking up. There were many, many crashes and serious incidents caused by co-pilots being unwilling to speak up in the moment when they saw harm about to occur, or when they had suspicions that harm were about to occur. Some would remember Korean Airlines had a most appalling safety record. And there were a number of crashes with Korean Airlines where, because of cultural reasons, first officers would have rather died and did die rather than speak up to the captain. Now, interestingly, as I often joke, the passengers didn't have the same view as Korean Airlines pilots. They would actually prefer the pilots to speak up and have survived. And so similarly in healthcare, if you talk to patient groups or consumer advocates, they assume that we're already there. They have an assumption that in healthcare, if we have any concerns amongst ourselves, that we speak up. But in fact, if you look at the research and studies, we're far from that level. Typically, when we started this program, it was not uncommon to find 50 to 60% of staff saying they were willing to speak up to any person or in any situation. But on the converse, a third or even 40% saying that even if they felt someone was about to be harmed, or even if they felt that a person was behaving, a colleague was behaving in a way that threatened safety, that they would not speak up, that it was too dangerous, that there were too many consequences for them. And from my view, from an ethical point of view, to me, this is totally unacceptable. In 2021, in a safety business like healthcare, to think that we have a situation where anyone would feel that it's not safe to speak up is almost intolerable. I've often heard over, my 21 years as medical director of Cognitive Institute, people exhort healthcare workers to have courage and say, we need people to have courage to speak up. But in fact, that in itself is a damning indictment. You should not need courage to do your job in healthcare. If you need courage to speak up, it actually says there's something fundamentally wrong with the culture. One of my good friends, who was a former chief pilot in British Airways, made the comment to me one day that in British Airways, you need courage not to speak up. That in fact, the consequences and the danger for you from not speaking up are higher in the culture of British Airways than they are for speaking up. And so I often label this program or underwrite this, eliminating courage is a prerequisite for being a healthcare professional. You should not need courage to come to work in a hospital. That to me is an absolute cultural failure. And so that's why 5 or 6 years ago, we put together the program as it exists now, the Speaking Up for Safety program. Just want to highlight the thinking behind putting this program together. Prior to the launch of this program, Cognitive Institute used to do quite a bit of work going into organisations and units where there was underperformance, that there were cultural issues. We'd get a phone call, there's an intensive care unit here or a labour ward here where we've got, a toxic culture or bad behaviour. And we would try and help out and assist in those circumstances. And it became very clear to me that we were the ambulance at the bottom of the cliff. We were being called once the culture had completely disintegrated or an unprofessional behaviour was rampant. And we made a deliberate and conscious decision to no longer do that work and refocus our efforts to try and get at the top of the cliff to stop units and hospitals getting into that position in the first place. It's also very important to remind you that there are two, and this comes to where you are in your stage of implementation. There are two types of speaking up that are required. The first is the obvious one. If I'm a surgeon and I'm about to chop off the wrong leg, or if I'm a nurse and about to give 10 times the appropriate dose of a medication, in other words, a patient is about to be seriously harmed, then we need someone to speak up right now about that imminent threat. But there is also a second type of speaking up, which in fact is much more important when you look at the numbers. And that is speaking up when you believe that the culture is actually under threat. So not that you're about to chop off the wrong leg, but rather the way you behave and could conduct yourself is inevitably going to lead to harm. So an example I commonly use is we obviously have a high focus on hand washing in hospitals. We know that most hospital-acquired infections can relate directly back to low rates of hand washing or people not washing their hands. And typically, potentially in the pre-COVID days, it was not uncommon to find that hand washing rates sat at about 80% if you audited them. The chances of me giving a patient a life-threatening or mortal, a fatal infection because I didn't wash my hands once are very, very low. But if the default position is I never wash my hands, then I'm going to kill someone. May not be today, maybe in a month's time, year's time. We may not even know that it was me who killed the patient. That the root cause analysis may never trace it back to me. But if we've got someone in our hospital who never washes their hands, they're going to kill people. And so what do we do about that? The risk of harm is not immediate, but we've got a cultural issue. Likewise, if we have someone who's exhibiting bullying behaviour, someone who is disrespectful, we know that this has a profound impact on the performance of other people in the room and will lead them to make mistakes. A common analogy or a common example I use in this program is the surgeon, for example, who repeatedly turns up late for their operating list. We know that emergencies can happen, but if I'm the sort of person who routinely turns up 10 minutes late for theatre, we know what the staff and the other people in the room will do for the rest of that list. They will play catch up. They will start taking shortcuts. They will maybe miss a break. And because they miss a break, that we know that decisional fatigue occurs as quickly as 90 minutes. The chances of them actually taking hard decisions or challenging themselves decreases dramatically if they don't have a break within a 2-hour period. And all of these factors could lead to, throw in an emergency case and suddenly we're even further behind. And this can lead to an error at 7 o'clock at night. And our investigation systems are so primitive that we never trace this back to the fact that I turned up 10 minutes late in the morning. We'll analyse the event that happened at 7 o'clock at night, but unlike the aviation industry, we won't go back to say, so how did we get into this position in the first place? And so it takes a lot of courage at the moment for a 19-year-old student nurse to come up to a man of my age and say, Dr. O'Brien, I noticed that you always arrive late for theatre. That's a threat to our safety. But that's what would happen in an airline, and that's what would happen in a nuclear power plant, but it doesn't happen in healthcare. So it's not just about chopping off the wrong leg or giving the wrong dose. It's also about people speaking up when they believe that someone is behaving in a way that undermines our culture. So the terrific work that you've done by way of update, my understanding, and I'm going to rely on Shannon and Kirsten to help me out and correct this old man if he gets it wrong, but my understanding is that you've got to about 85% of your staff with the Speaking Up for Safety Part 1, which is training everyone in a standard language in how to speak up in the safety code. This is a model I developed about 15 years ago, and we've implemented it across hundreds of hospitals and health services across the world now. We know that when we train people to speak up, and particularly when we give them a standard language, their chances of speaking up increase quite dramatically. We've got, I think I may even have a slide to show you in a second, where you can expect that you might go from 50 to 60% of people saying that they would speak up to 70 or 80 or even 90% of people saying they would speak up, which is a tremendous change. We know from the research that no matter what model you use, having standard language really makes a difference. But the problem is it doesn't go to 100%. There's still 10% of people who say, you can train me 10 times over and you can put up all the posters in the world, but it's not safe for me to speak up to Mark O'Brien. He could threaten my career. I've got to work with him. I know his personality. He will be vindictive. Or in fact, I spoke up to him and it made no difference at all. I plucked up the courage to say, look, I've got a concern about this. And he slapped me down. So what do you do in that space? What do you do when you've trained a large percentage of your staff, if you have, and you've hopefully seen the huge benefits of having a standard language, but you haven't seen the full transformation that says, but there are still these people who we can't speak up to. So what happens if it's not possible, safe, or effective to speak up? And that's where we go to the second part of the program, the Promoting Professional Accountability program. This is a program developed by a colleague of ours, a pediatrician in Nashville in Tennessee called Jerry Hickson. And this program and variations of it have been conducted for nearly 20 years in the United States and in Canada. And essentially it involves a model where people feel that they can't speak up in the moment to a person such as myself for whatever reason, that they have the option of asking the organisation to speak up on their behalf, to actually send a messenger, a peer messenger, someone who is of the same, if you like, tribe. So if it's a doctor, it's another doctor. If it's a pharmacist, it's another pharmacist. To basically pass on the message that the person felt that they couldn't pass on face to face. Now, I won't go into, it's not actually just as simple as that. It's a whole system with lots and lots of safeguards, an implementation program that goes to examining your policies, your HR procedures, that essentially puts in place infrastructure. But the net result of it is a system whereby if someone feels that they can't speak up, that there is an alternative mechanism for them to speak up via a proxy. And the feedback is provided to the person initially in a non-judgmental, non-investigative way. I often refer to it as a rolling 360. Every year we have a 360 process in our office, and Shannon and Kirsten can pass on to me any information they'd like me to hear anonymously. I take that on board, and every time I receive feedback, I listen to it and try to respond appropriately. But if they, for example, Shannon put something that, she felt that I was rude in the office, that feedback would be passed on to me and I would have to reflect on that. There's no investigation done. I'm not disciplined. It's a chance for me to reflect on my behaviour. And in the early, if you look on this triangle, in the informal cup of coffee level and the level 1 awareness intervention, these are simply feedback mechanisms to pass on the concerns that colleagues have about professional behaviour. Now, should those concerns not be addressed by the person, so if after typically 3 or 4 feedback conversations, the person continues to, we get reports of a person continuously acting in a way that undermines our culture, then we have the option of going to level 2 and 3, which are essentially HR processes. So that if a concern gets to a level where we're saying we've had 4 reports or 4 feedback requests for Mark O'Brien, and we've never had more than 1 or 2 for anybody else, we're concerned about this. If we continue to get reports, we need to see whether there's any truth to these. And if there is truth to these, then we need to start investigating to see whether there's truth. And of course, if we find truth, then we want to work with the person to address the issues. But on the other hand, if the person continues to not address the issues, then we will start a formal HR type process or performance management. And ultimately, if a person doesn't respond, then they will no longer work at the organisation. Now, for those board members who weren't originally weren't at the original presentation, one of the critical elements of the board is what we refer to as don't blink. And don't blink is that the board, your board, in agreeing to do this program originally, passed on to Cognitive Institute. In fact, it's a prerequisite of working with us, that no matter who goes up the pyramid, no matter how senior, no matter how important they are, it doesn't matter who they are, if they continue to behave in a way that is unprofessional, they move through the system and go through every level, including performance management, and they still behave in ways that undermine a culture of safety, that the board will take action to ensure that they are not a risk to patients or the community. So that conversation has already been had. So across the world, like obviously COVID changed things quite significantly 12 months ago. Across the world, we have about 250 hospitals and healthcare groups that have undertaken that are undertaking or partially way through implementing the Promoting Professional Accountability program. We have, I think, close to 250,000 healthcare workers working under the program in our part of the world. There are much bigger numbers, of course, in the United States and Canada, where this is probably, I forget the actual number, I think it was closer to 450 healthcare systems that use the system in North America. So this is not a new system. It's not something that's particularly controversial. My last reckoning is I think that we were around 60% of the district health boards in New Zealand have either implemented the system or are in the process of implementing it. Obviously, COVID was a major blow because a lot of the implementation of this program involves face-to-face training, quite an extensive leadership training. It has been a challenge to think, and we've been struggling with this, both under the license arrangements we have with Vanderbilt University for this program, but also we're not sure about the validity and the processes around face-to-face training for cultural pieces of work. For many of our programs, we have chosen not to put them online because we believe there's not an evidence base. And given the amount of time that's involved for clinicians, we've been very careful to make sure that we're not suggesting or representing that an online experience around leadership training is the equivalent of face-to-face. So we've been working through that, and I believe I've not been involved in those negotiations or conversations with you guys, but through Kirsten and Shannon and through the Deputy Medical Director, Dr. Stephen Walker, my understanding is that there is some progress on that, and we will be looking to trial some online training in this space. But I want to be really honest with you, we don't know yet whether this is going to be equally effective. So there are sites that we are piloting. We've made a commitment that we know how resource intensive this is, and we don't want you to be we don't want any site to fail. So we've been extremely cautious, both in exploring online delivery of this module, and indeed we would not be taking widespread online delivery of any of our programs until we've actually done some piloting and believe that it actually does lead to similar outcomes to the intensive face-to-face training that we traditionally have undertaken. I mentioned there was a slide. This is from one of our hospitals who implemented the Speaking Up for Safety. They're at the stage, when they did this study, they were at the stage that you are now, where you've had excellent implementation of stage 1. And this was the sort of change that they found when they surveyed their staff. You can see it's a dramatic improvement. So we would hope that you would already be seeing improvements in your speaking up culture, but it's nowhere near 100%. Even in this excellent hospital, there are still seriously 10% of patients saying they're not confident, 10% of people in the organisation saying they're not confident to speak up to everybody. And that's really concerning. And that's why you need a second program to the PPA to fill that gap. The reason we went with the Promoting Professional Accountability program from Vanderbilt was because of the strong evidence base behind it. Vanderbilt University is one of the top 5 university systems in the United States. Jerry Hickson and his team are prolific researchers. And so rather than just saying, here's a program that looks good or we think might work, we can say with you with absolute confidence that if you implement this program as designed, you will get the results. We've had hundreds of locations across the world implementing this program. You won't be surprised to hear at all that we've seen variation in performance. We've seen some hospitals whose implementation has been outstanding, and they are reaping the enormous benefits of the program. To be blunt, we've had 2 or 3 hospitals who essentially have gone a little bit off the rails. They started modifying the program. They said, oh, we'll take this shortcut. Oh, we do it slightly differently here, often against our advice. And not surprisingly, they've come back telling us that the results have not quite been what they expected. I can't emphasize enough how we are implementing a system. This is not an idea. This is a proven system that works across many cultures. And the prerequisites for success are essentially implementing the system as it exists. For example, let me give you an example. In the system, the typical process would be once 3 or 4 feedback conversations have been conducted with someone, they would be elevated into an investigative phase. So in other words, if reports kept coming in, the organisation would start investigating and engage with the person saying, we are investigating to see if there's any truth that your behaviour undermines our culture. And indeed, that if it continues, we will start performance managing you. Recently, I was with one hospital who were really saying, look, we're not sure that we're getting the results that we should have. I discovered that they had one person who had 9 reports and they were still sending feedback messages. And the reason was, oh, they're very important. They're very senior. Well, can you imagine the message that sends to the entire organisation? So one of the other things that I to be blunt, that I say to organisations is that the involvement of Cognitive Institute is actually quite short. In implementing this program, we would typically be involved with an organisation for 9 to 12 months, but cultural transformation takes 5 to 7 years. Once we leave, we have no power. We can give you the best tools in the world, but if you misuse the tools or you let them sit on the desk or on the shelf not being utilised, or you utilise them badly, then you will not get the results. But I can also confidently say, on the other hand, that if you utilise the system as implemented and designed, you can expect extraordinary results, as you'll see from some of the research studies that I'll briefly mention, but that we can provide to you from our colleagues at Vanderbilt. One of the other really important things that you as a board need to be fully cognizant of, as I do as a board member, when I see reports coming through of bad behaviour, aggressive, yelling, intimidating staff, bullying, pretty topical in our country at the moment. I'm sure the the mischief happening in our parliament has has transmitted across the Tasman, a national embarrassment to us all. It's a lot of it is focusing on the aggressive spectrum of disruptive behaviour, but you need to be very cognizant as a board that when you look at the research around what is disruptive behaviour, the passive stuff is much more toxic when it comes to patient safety. Much of the harm in healthcare is done with a smile. I can say things like, oh no, I'm not doing that safe surgery checklist, but you have my full support. Go ahead. I'm just out in the tea room having a cup of coffee. No one's yelling, no one's shouting. I can smile while I'm looking on my phone during handover. Oh, no, sorry, I'm just checking a few messages. You guys go ahead with the handover. No abuse, no yelling, no swearing. Which do you think is more dangerous? The use of a four-letter word or someone not paying attention during handover? Well, let me tell you that 70% of sentinel events in hospitals are caused by failures of interprofessional communication. Not paying attention during handover is one of the most dangerous things that happens in hospitals. But it's often done passively. It's often done, by people who are repeat offenders. My wife is a registered nurse. She often describes a particular person in her team that is on their phone all the time during handover. And the people feel they can't speak up to this person. Just to give you an idea of the toxic effect of this behavior on performance, this is a study done in pediatrics. And what they did was a double-blind crossover trial of simulations in pediatrics, a whole range of pediatric emergencies. And in the intervention group, they asked one person to behave rudely, and in the control group, they basically just asked people to behave normally. And look at the impact of just one person behaving rudely. The performance of others in the room was dropping by 40 to 50% in key performance areas. We've been often asking the wrong question in healthcare. We've often asked the question, is Mark O'Brien a good performer? That's an important question, but there's an equally important question, which is, what is the impact of Mark O'Brien on the performance of others? And what we're finding is that the latter question is more important, because I may be making no mistakes at all, but I may be an error-inducing machine in others. My presence may cause other people to seriously underperform. Just the way I speak, the way I conduct myself. Here's a study looking at surgeons conducted by Vanderbilt and other healthcare systems in the US. This study has now got up to 32,000 operations. And what they found was they equalized or standardized all of the risk factors and the confounding variables, and then looked at complication rates amongst surgeons across 6 areas: intraoperative, wound, urinary, central nervous system, respiratory, and others. And what they found was that complaints of rudeness, complaints of inattentiveness had a direct impact on the rate of complications. The more complaints of rudeness or inattention from patients, the more likely the surgeon was to have complications. Nothing to do with their technical ability. This was an important study that was published last year looking at anesthetic registrars, so anaesthetists in training. What was the impact of rudeness? Very similar to the pediatric study. What's the impact of rudeness? One rude person in a whole lot of simulated operating room crises. And again, what you find is that one rude person in the room led to a 4-fold increase in anaesthetic registrars underperforming. So in other words, those registrars would have performed as expected had there not been a rude person in the room. But as soon as there's one rude person, they're 4 times as likely to underperform, 4 times as likely to make mistakes. So simply asking, is Mark O'Brien making errors, is just not enough. You have to ask, what is the impact of having one rude person, one person who is disrespectful, one person who doesn't pay attention during handover or doesn't wash their hands on the performance of others? through their role modelling, through their intimidation. So the Promoting Professional Accountability program, as you can see across the bottom, I'm conscious of the time, I will speed up. Across the bottom, you'll see there are many papers that have been published over the years by the group in Vanderbilt. There are more modern papers that Shannon and Kirsten can direct you to if you want to find out some of the latest research. I'll show you one of the pieces that did come out from Vanderbilt in June 2019. And this was looking at what was the correlation between the number of reports that a surgeon got and the chances of patients suffering wound infections, pneumonias, blood clots, kidney failure, stroke, and heart attack. It turns out that if just one person in the organisation says, I can't speak up to Mark O'Brien, could you pass on a message of feedback to him that I've got a concern? Me just having one report correlates with an 18% increase in risk in my patients of them getting all of these complications, every single one of them. And if I get to the point where I have 4 reports, or 4 people requesting that I get feedback, it rises to 32% increase. Now, if we had a drug that could reduce surgical complications across the board by 18%, we would be spending billions of dollars putting that into healthcare. And yet, this happens in every hospital every day. And it continues to happen. So this, to me, just reinforces the incredible cost we pay as patients, as clinicians, and as systems of failing to address unprofessional communication and behaviour. Some people have made the very pertinent report that most of the studies that I quote refer to doctors. And that's because our colleagues at Vanderbilt have particularly focused on medical practitioners. But it's reassuring to see that there are similar reports coming out in nursing and in allied health. And surprise, surprise, there's no difference. The nurse who behaves disrespectfully has just as much impact on the performance as others as the doctor who behaves disrespectfully. I think doctors have been investigated because the impacts are so dramatic and the costs in terms of medical litigation and complaints are so high. But people are people, humans are humans, and there's no reason at all to suspect that this doesn't apply across the board. So at that point, I might actually pull up stumps just to say that my understanding, and I'm going to ask my colleagues Kirsten and Shannon to help me out here. Kirsten is our implementation guru. She is just an extraordinary repository of expertise and knowledge of all of these sites across the world. She's done an extraordinary job. And Shannon works with hospitals across the globe to get all the pieces right. I'm just the old guy the talking head, if you like. My understanding is that you've done an extraordinary job of phase 1, and we are in the process of getting ready for stage 2 and have done some work. But again, blindsided like all of us by the COVID crisis. But my understanding is that we are moving to make you one of the pilot sites of our online delivery because we want to support you, but we also want to risk manage and make sure that we don't waste your resources and time delivering a program that is not effective. So perhaps Kirsten and I might ask you to make a quick comment, and if I could then throw back to the board. Thank you so much for your time, and very happy to take questions in the remaining time as well.
Thank you, Mark, and good morning, everybody. Thank you so much for taking the time to meet with us. In terms of the background, certainly, as Mark said, we've all been blindsided by the global incidents with COVID. Your staff had made great inroads into the speaking up for safety training. And like many organisations, over time, there's a natural attrition where you do lose some people. But my, congratulations to reaching 80% of staff through the program. But what we often experience is a bit of a stall at that 80% because you think, oh, we've got such a good number, will that help? So it does need an extra push at this point to keep moving into the right direction and getting as many staff as you can. There's also the element of making sure that the SUFS presenters, so the staff that have been trained to support your workplace, get a sense that they are achieving and that they are getting that message out to staff and having a clear sense of what comes next. And that's where it's really important that the board and the project implementation team keep that communication open. It's ironic that it's one of those non-technical skills, but keep communicating with the SUFS presenters of what your intention will be, and a real focus on how we'll implement, how long it will take, and the support from board level right through the organisation, that we're not going to blink, as Mark suggested. I will actually defer to Shannon. I've slipstreamed in between borders closures and actually been interstate for several weeks trying to help some organisations with catch-up training. So Shannon is more up to date than me at this point with the pilot testing. So Mark, I'm going to hand that one to Shannon. Shannon, if you could.
Yeah, sure. Thanks, Kirsten, and good morning, everyone. Really, with the pilot testing, we're probably looking at Q3 for a rollout for that, because there is quite a bit of work that needs to be done in the background. But we'll keep communicating with you to ensure that you're kept up to date with the progress that we're making in that space.
Well, kia ora koutou. Thank you very much for joining us today. It's very heartening to hear that that you're characterising us as having done exceptionally well in stage 1, and that we just need to give a last bit of a push, and also to hear that plans are in trade to go to stage 2 with promoting professional accountability. I am, like you, very conscious of time. We're galloping towards trying to get to quite an important part of our board meeting at midday. So I will ask any of our board members if you've got any specific questions to pose. Jim, do you want to make any comments?
No, just will make one comment around it. It's really good to hear about the pilot program around distance. I think, we were hoping that the transportation bubble would help with that, but it hasn't yet. It may still, but that backup.
Jim, I'm sorry, it's Mark here. I'm struggling to hear you, Jim. We can't actually hear exactly what you're saying.
Mark, I was just saying it's good because I did talk with your team just a month or so ago about the distance learning opportunity for this, and it's good to hear that that's moving right well. So we're kind of like between the trans-Tasman bubble happening and this as to move on forward. So we're really looking forward to that, and thanks to your team for making that possible.
Yeah, thank you, Jim. Look, our clients have really been wonderful. I'd have to say, I mean, so many of them were thrown into absolute turmoil with COVID, and we know that many programs have moved online very quickly. But in our analysis of that, we've found that many of those programs are actually information-based programs, whereas cultural training and cultural transformation, we've been analysing, and I've certainly been watching through Oxford. And it's interesting, Oxford has been very cautious, and most of their programs still are not online even after a year, despite the fact that they're in total lockdown, because of their grave concern about what is the impact of online training. Some of the research coming out showing that in online training, the attention of people is degrading as quickly as 20 minutes. That human brains are just not capable of taking in hours and hours of work on a screen. So it's a real area of concern. I'm sure we could have the level of being overcautious, the accusation of overcautious being labelled at us, but when you think of the hundreds of hours of your staff's time that's involved in training this program, to do it and find it's ineffective is a real risk. And so we're very cautious, but we're excited that you will be one of our pilot sites for this.
So Mark, we are going to have to move on. Oh, there's one more question.
Oh, kia ora, Mark. I just wanted to wish you all the best in your new role, and thank you for sharing today in this space. Your last presentation, respect here at the Tākara Brown. I do recall meeting that you're speaking up for Safety Collective Institute. You mentioned social media, because I think social media is where people are thinking is a speaking up for safety mechanism and being autonomous or, not having anyone really kind of look after that space, even though freedom of speech has been challenged. But in your program, we're trying to get people to change a culture of speaking up for safety, noting this. I'm seeing this be helpful in other places, not just health. So do you go into other governance spaces like councils and other spaces where speaking up respect to rudeness? I was really impressed with that kōrero. But I just wonder, where else does this framework sit and what happens afterwards? You just keep staying in touch with the case studies. How do we keep this up?
Look, what a great question, and thank you for your kind words. And if I would allow, if the board would indulge me for 10 seconds, if I can put in a plug, board members are welcome at the Healthcare Leadership Program at Oxford, so keep an eye out for that one.
Funding.
So very quickly, look, it's so interesting. I gave the keynote address at the Australian Barristers Association conference in Australia just before lockdown last year, and I have been inundated with judges, barristers and lawyers asking, can we run a program identical to this in the legal system in Australia? I'd have to say Cognitive Institute is so busy in healthcare, we've probably got about another 30 years just to get around the hospitals. So, but look, so there's a business opportunity for a keen board member there to start their own business.
Mark, we've just got one question from one of our members on Zoom.
Kia ora. Kia ora, Mark.
Kia
I hope you can see me. I chair our Indigenous Māori Relationship Board for Hauora Tairāwhiti, and when I hear you talking about culture, and I get that you mean the culture of an organisation, I just wonder though, in terms of speaking up for cultural safety and what that means in terms of the program. You don't need to answer this. I guess I see you're a bit choked up about your last presentation, but I wanted to leave that with you because we have a strong emphasis here on inequity and the reduction or getting rid of inequity within our system and how that applies in this program going forward. As I say, you don't need to answer that, but it's something to think about.
Thank you. Look, just a very quick comment. The system is a patient safety system because of the strong legal grounds the board and the executive stand on when they take action at the highest levels if it's a patient safety issue. But what you're saying is absolutely pertinent, and we talk about it in the training. Cultural insensitivity is another form of rudeness. It's another way that impacts the performance of others. So it's certainly mentioned and talked about in the training because whether it's Maori culture, whether it's our Indigenous cultures, or even if it's just even gender-based, if male versus female or people of different sexual orientation, if they don't feel accepted and respected at work, then this has a cognitive impact on them. They will underperform, and it can actually become a self-fulfilling prophecy. You can actually make a group who feels not listened to actually underperform, and it reinforces a stereotype. So it's really important stuff. So thank you for raising it.
Thank you, Mark. And can I just make a plug for our regulatory authorities? Both our Medical Council and Nursing Council do have cultural safety professional standards for doctors and nurses. So it's actually more than an insensitivity. It's a professional standard that they must. Yes. Look, can I just underscore the voices of our board on congratulating you on your new appointments and thanking you for your time you've spent with us and for all of the many, many years that you've put into Cognitive Institute and the education of health professionals, not just in our country, but across the world. So ngā mihi kia koe. I know it's a big day for you today, and thank you for spending part of it with us.
Thank you, Mark.
Kia ora, Mark.
Thank you very much, everybody. Thank you.
Thank you.
Thank you.
Thank you.
I'm very conscious that our time is galloping on us. We have got a really important agenda item that I want to deal with over the after lunch. So what I'd like to do now is to gallop us through the last couple of items in our public agenda. I think they're very short items. One is the revenue provider revenue summary, and the other is the health partnerships strategic direction. If need be, we can circle back to a further discussion on COVID after lunch, but I really want to get our board and CEO only time done before we start to lose members because of other commitments. So we'll finish public, grab our lunch, have board CEO only time, and then do our non-public after that.
Kate Paitena.
Okay, so just for the balance of our public agenda, noting that we may need to circle back to discussion on COVID, although I don't think we will, but we'll deal with that later. So there is the provider revenue summary report at page 6. So was there anything in particular we needed to do with that, Joe?
No, I'm not. Yeah.
This is an information item. Very good, noted. Thank you.
I'd just like to congratulate you on your new position, your new title of head of the poets.
No, the Bard Chair.
The Bard Chair.
Yeah.
I'm
such a Yana.
Quiet.
The last item on our public agenda is the approval of the Health Partnership Strategic Plan. So just by way of background, Health Partnership replaced what was Health Benefits Limited. They undertake a range of activities on behalf of all DHBs, particularly around procurement, and their drive is really to realise better value for the $4 billion that we spend on products and services across the country. And it's not just financial benefit, they're looking for value. So their strategic plan came out seeking board chair approval, which I have done on behalf of our board. It actually came out, I think, on the 15th for approval yesterday, and then they changed it to the 17th. So I just went through it and said, yes, that's fine. We are a shareholder, and so so although I have approved it already, I'm seeking board endorsement of that action that I've taken.
Yeah. Yes.
Can I just a little thing, not to hold it up or anything. I just wanted to go to the philosophy behind this thing. I'm suggesting here that I was concerned on page 80 when it talked about potentially engaging with the future MHA. And I just thought to myself, are we engaging as a competitor to Māori organisations accessing that sort of funding? And I just wanted to seed that in for us to keep an eye on that. And the other thing I wanted to ask too, say like on page 82, it talks about our collective thinking. It seems like, and I stand to be corrected, but it seems like Māori have been outside of this process, as if when it comes to health, there's a certain angle that, we must subscribe to. So if we talk about the Referral report, which identifies the Māori economy, I'm just suggesting to us that let's not, in the next, because this is a 3-year plan, I think it is, 3-year strat plan. I'm just suggesting in the future we might want to think about how Māori can be part of the driving force in these partnerships.
We absolutely can. So as we're a shareholder, and as a shareholder, we can say, actually, these are the sets of things that are important to us. We're one of 20 shareholders. But so Māori have been no more outside of this process than DHBs have kept them in or outside of the process as the shareholder. And so, yes, certainly we can take that on board and run that kind of thinking, I think, up through the whole of Chairs Forum, who sort of do this level of work with health partnerships.
Yeah, I was just going to suggest, though, that we might, as part of the thinking going forward in the next 3 years, is about developing a plan of how that might look in the next set of strategic thinking for the next strat plan, April 24, I think it is.
We can have a yarn about that.
Yeah.
All right, I'm going to move us into public excluded as per the narrative on the agenda of our papers that have been published. Can someone please second that?
Thank you. We're now in public excluded. Now stay on the line, and to those members of the public who have joined us, thank you very much for joining us today. It is a pleasure to have you with us. And we are always encouraging you to continue to participate in local democracy and service provision in this way. Kia ora tātou.
Don't know yet.
Can we mute ourselves?